PTSD, The Brain of Those with Dissociative Amnesia or Acute Stress Disorder by Jennifer Wartz. Narrated by Brandon Suku. Chapter 1. Post-Traumatic Stress Disorder. Post-traumatic stress disorder, or PTSD, is a painful trauma and stress-related disorder that may develop after direct exposure to an occasion or experience in which death or serious physical damage occurred or was threatened. Most people who experience the disorder include Army troops, rescue workers, and survivors of shootings, bombings, violence, and rape. Family members of victims can develop the disorder also through vicarious trauma. PTSD influences about 8 million American adults and can happen at any age, which includes childhood. Women are more likely to develop the disorder than men, and there is some evidence that it may run in families. PTSD is frequently accompanied by sadness, compound usage disorder, and anxiety conditions. When other conditions are appropriately detected and dealt with, the probability of effective treatment increases. When symptoms develop instantly after exposure and continue for up to a month, the condition might be called acute stress disorder. PTSD is identified when the stress symptoms following exposure have persisted for over a month. Delayed expression of PTSD can occur if symptoms arise 6 months or more following the beginning of trauma. Approximately 30% of Vietnam veterans developed PTSD. The disorder also has been identified in as many as 10% of Gulf War or Desert Storm veterans. About 6% to 11% of veterans of the Afghanistan War, and about 12% to 20% of veterans of the Iraq War. For veterans, aspects related to battle may farther increase the risk for PTSD and other mental health issues. Those include the veteran's role in the war, the politics around the war, where it was combated, and the kind of adversary faced. Another reason for PTSD in the military is Army sexual trauma, or MST, or sexual harassment or attack that happens in the armed force. MST happens to males and females and can occur during peacetime, training, or war. Among veterans using VA healthcare, about 23% of women reported sexual assault while in the Army. 55% of women and 38% of guys have experienced sexual harassment when in the armed force. Symptoms. Many individuals with PTSD tend to re-experience aspects of the terrible event, especially when they are exposed to events or objects reminiscent of the trauma. Anniversaries of the event and similarities in person, place, or situation can activate signs. Most people with PTSD experience invasive memories or flashbacks, psychological feelings of numbness, sleep disturbances, anxiety, intense guilt, unhappiness, irritability, outbursts of anger, and dissociative experiences. Lots of people with PTSD might try to stay away from situations that remind them of the ordeal. When symptoms last more than 1 month, a diagnosis of PTSD might matter. Signs connected with reliving the distressing event. Having bad dreams or stressful memories about the event. Behaving or feeling as if the event were actually happening all over again, known as flashbacks. Dissociative reactions or loss of consciousness of present surroundings. Experiencing intense feelings when reminded of the event. Having intense physical feelings when reminded of the event, heart pounds or really missing a beat, sweating, trouble breathing, feeling faint, or feeling a loss of control. Symptoms connected to avoidance of reminders of the distressing event. Avoiding thoughts, discussions, or feelings about the event. Staying away from people, activities, or places related to the event. Symptoms connected to negative changes in idea or mood. Having difficulty remembering an important part of the original trauma. Feeling numb or separated from things. Absence of interest in social activities. Inability to experience positive moods. Pessimism about the future. arousal and reactivity signs, sleeping troubles, consisting of trouble falling or staying asleep, irritability and outbursts of anger, difficulty concentrating, feeling easily stunned, excess awareness or hypervigilance. Other symptoms associated with depersonalization, feeling like an observer to somebody's body and thoughts or feelings, or derealization, which is experiencing unreality of environments, may also exist for some individuals. Causes. The cause of PTSD is unknown, but mental, hereditary, physical, and social aspects are included. PTSD changes the body's reaction to stress. It impacts the tension, bodily hormones, and chemicals that carry information between the nerves. Most people who have suffered childhood abuse or other former terrible experiences are likely to develop the disorder, at times months or years after the trauma. Unstable variables such as externalizing behaviors or other anxiety issues might also increase risk. Other environmental risk factors include family dysfunction, youth hardship, cultural variables, and family history of psychiatric health problems. The greater the magnitude of the trauma, the greater the risk for PTSD, experiencing atrocities, severe personal injury, perpetuating violence, inappropriate coping systems, absence of social support, family instability, or financial tension might farther get worse from the result. Other factors called strength aspects can help reduce the risk of the disorder. Some of these strength elements are present before the trauma, and others become important throughout and after a distressing event. Durability elements that may minimize the risk of PTSD include seeking out support from other individuals, such as psychological health professionals, family and friends, finding a support system after a traumatic event, feeling good about one's own actions in the face of threat, having a coping technique, and having the ability to act and respond efficiently in spite of feeling fear. Treatment. Treatment for PTSD normally begins with a detailed evaluation and development of a treatment strategy that meets the special needs of the survivor. The main treatments for people with PTSD are psychological therapy, medications, or both. Due to distinctions in experience and repercussions of the trauma, treatment differs and is customized to the symptoms and needs of the person. Treatment by a psychological health care provider who is experienced with PTSD enables people to lead more well-balanced and functioning lives. Some individuals with PTSD might need to try different treatments to see what works for their signs. If a person with PTSD is going through a continuous trauma, like remaining in a violent relationship, treatment might include helping find security. PTSD-specific treatment can begin only when the survivor is safely gotten rid of from the dilemma situation. Individuals who experience other symptoms of panic disorder, depression, substance use disorder, and those that feel suicidal may need treatment to focus on those problems too. Other methods for treatment include educating trauma survivors and their families about dangers related to PTSD, how PTSD impacts survivors and their loved ones, and other problems commonly related to PTSD signs. Comprehending that PTSD is a clinically recognized disorder is essential for reliable treatment. Direct exposure to the event by means of images allows the survivor to re-experience the event in a safe, controlled environment. An expert can thoroughly analyze reactions and beliefs in relation to that event. Examining and dealing with strong emotions such as embarrassment, anger, or guilt, which are common amongst survivors of trauma. Teaching the survivor to handle post-traumatic memories, reminders, reactions, and feelings without avoiding them or becoming overloaded or emotionally numb. Trauma memories usually don't disappear totally as a result of therapy, but new survival skills can make them more workable. Medication. The United States Food and Drug Administration, or FDA, has approved 2 medications to deal with adults with PTSD: sertraline, or Zoloft, and paroxetine, or Paxil, which are careful serotonin reuptake inhibitors, or SSRIs. Both of these medications are antidepressants, which are also used to deal with depression. They might help you manage PTSD symptoms like unhappiness, concern, anger, and like feeling numb. Using medications collectively with treatment or just before starting treatment might make treatment more effective. If an antidepressant is recommended, it may really need to be taken for some days or weeks before offering considerable enhancement. It is very important to not get discouraged and prematurely stop taking medications before they have had a chance to work. An adjustment in dose or a switch to another SSRI might help resolve these issues. It is very important to work collaboratively with your medical professional. At times, people taking these medications experience bad effects. The results can be frustrating, but they usually go away. Though medications influence everyone differently. Any bad side effects or uncommon responses should be reported to a medical professional instantly. The most common bad effects of antidepressants like sertraline and paroxetine are headaches, which usually disappear within some days, nausea, which usually disappears within several days, insomnia or drowsiness, which may take place throughout the first few weeks but then disappears. In some cases, the medication dose needs to be lowered or the time of day it is taken needs to be adapted to help reduce these adverse effects. Agitation or feeling tense. Sexual problems, which can impact both women and men, and that includes reduced sexual drive and issues having and delighting in sexual acts. There are other types of medications that medical professionals may also recommend, like the following. Benzodiazepines may be given to help people unwind and sleep more easily, although there is potential for developing dependence. Antipsychotics might be prescribed to people who experience more extreme agitation, suspiciousness, or fear. Other antidepressants like fluoxetine or Prozac and citalopram or Celexa can help people with PTSD feel less tense or sad. For those with PTSD who also have other anxiety disorders or sadness, antidepressants might work in reducing signs of these co-occurring illnesses. The potential bad effects connected to the application of these medications include a dialogue with your company. Likewise, antidepressant medications called tricyclics are given at low doses and slowly increased. Tricyclics have been around longer than SSRIs and have been more commonly studied for dealing with anxiety conditions. They are as reliable as the SSRIs, but many doctors and patients prefer more recent drugs simply because the tricyclics at times cause lightheadedness, dry mouth, drowsiness, and weight gain. The mood stabilizers such as lamotrigine and divalproex salt may also be helping in treating symptoms. Psychological therapy. Therapy is well regarded in the treatment of PTSD. It involves talking with a mental health professional to work through the experience and its influence on the person. Psychotherapy can take place one-on-one or in a group format. Treatment for PTSD usually lasts till the individual has learned to manage and handle their experience and has the ability to be more functioning. Many kinds of psychotherapy can help people with PTSD. Some types target the symptoms of PTSD straight. Other treatments concentrate on social, family, or occupational issues. The medical professionals or therapists may combine different therapies depending on everyone's needs. Cognitive behavioral therapy, or CBT, has been found to be quite reliable in treating PTSD. There are several parts to CBT, consisting of direct exposure therapy. This treatment helps people be more knowledgeable about their experience. It may expose them to the memory of the trauma they experienced in a safe way. It uses psychological images, writing, or visits to the place where the event happened. The therapist uses these tools to help individuals with PTSD deal with their emotions. Cognitive restructuring. This treatment helps people make sense of their memories and experiences. sometimes people remember the event in a different way than how it actually took place. They might feel guilt or shame about what actually isn't their fault. The therapist helps people with PTSD look at what happened in a sensible way. Tension shot training. This therapy tries to minimize PTSD symptoms by teaching a person how to decrease anxiety when challenging anxiety-provoking situations. Like cognitive restructuring, this treatment helps people look at their experiences in a healthy way. There are also other kinds of treatment that can help people with PTSD, and a client may want to talk about with their therapist about treatment alternatives and treatment focus that may include finding out about trauma and its impacts, using relaxation and anger management skills, improving sleep, diet plan, and exercise practices, recognizing and handling guilt, embarrassment, and other feelings about the event, focusing on our response to PTSD symptoms. For instance, therapy helps people check out spots and people that are reminders of the trauma. Eye movement desensitization and reprocessing, or EMDR, is a treatment for terrible memories that include elements of exposure therapy and cognitive behavior therapy, integrated with strategies, noises, eye movements, hand taps, that develop an alteration of attention. There is some evidence that the healing element unique to EMDR, attentional change, may be helpful in retrieving and processing terrible material. Quick psychodynamic psychotherapy focuses on the emotional disputes caused by the distressing event. That treatment helps an individual comprehend how the past affects the way they feel now. Through the retelling of the terrible event to a calm and empathic therapist, the survivor accomplishes a higher sense of self-esteem, develops efficient ways of thinking and coping, and more successfully handles the intense emotions that show up throughout therapy. The therapist actually helps the survivor identify existing life situations that set off terrible memories and aggravate PTSD symptoms. Group treatment is a perfect restorative setting because trauma survivors are able to seek help and support while sharing distressing material in a safe environment. As group members accomplish greater understanding and resolution of their trauma, they usually feel more confident and able to trust themselves and others. As they discuss and share trauma-related shame, guilt, fear, rage, doubt, and self-condemnation, they learn how to focus on the present instead of the past. Telling someone's story and directly facing the sorrow, guilt, and anxiousness associated to the trauma enables many survivors to cope with their signs, memories, and lives. Family therapy is a type of counseling that includes the entire family, as PTSD can affect the whole family. One's kids or partner might not comprehend why the person snaps sometimes, or why they're under so much stress. They may feel terrified, guilty, or perhaps upset about the condition. In family therapy, a therapist helps the patient and family communicate, maintain some good relationships, and handle rough feelings. Each person can reveal his or her fears and concerns. It is essential to be honest about those emotions and to listen to other people. The patient can discuss PTSD symptoms, triggers, and fundamental parts of treatment and recovery. By doing this, the person's family will be better prepared to help them. Chapter 2. What happens in the brain? Comprehending what trauma does to the brain is critical for the development of reliable treatments for PTSD and has become a major focus of research. In PTSD, the stress circuitry in the brain goes awry, interfering with communication between some brain centers. Those include the amygdala, which generally keeps track of incoming understandings and red flag threats, putting systems on high alert and triggering the tension reaction. The prefrontal cortex, or executive nerve center of the brain, which typically senses when a threat is over and moistens amygdala activity, and the hippocampus, where memories are kept and retrieved. In PTSD, researchers find the prefrontal cortex is underactivated and the amygdala is overactivated. There is proof that a core issue depends on the connections between individual nerve cells, or synapses. There's a deficit in connectivity, restricting communication between nerve cells. As a result, individuals with PTSD lose mental flexibility. They stay stuck in an excessive reaction pattern, and their memories withstand the adjustment that generally occurs gradually. Research actually shows that some people are at a much higher risk than others for PTSD. Most susceptible are individuals who have a history of trauma exposure or mental difficulties. Having little social support or persistent ongoing life tension also runs the risk of factors. Physical problems and job loss also add to the risk. Treatment for PTSD. Treatment for PTSD typically centers around talk treatment, but new kinds of treatment are being made that combine talk therapy and medication in new and appealing ways for the 50% of victims whose symptoms aren't relieved by current techniques. Research studies say that it may even be possible to stop PTSD from taking place, specifically in high-risk circumstances. Psychiatric therapy, especially exposure therapy and cognitive reappraisal therapy, has proved to be one of the most reputable treatments for PTSD. The objective is to bring back cognitive versatility so that patients can discuss their bad experience and customize the emotional force of the memory. The use of drugs that boost the power of psychotherapy by directly increasing nerve cell connections is presently under medical investigation. Among those drugs is the anesthetic ketamine, in some cases referred to as the club drug Special K. It is already authorized for use in treating extreme depression. When given by injection, in show with a particular program of psychological therapy, it has been shown to substantially speed heal from PTSD, achieving in days what might otherwise take months. Another appealing path is psychedelic-assisted therapy with MDMA, also referred to as ecstasy or Molly. When given to PTSD patients right before a therapy session, scientists find it significantly speeds up the restorative process. It permits even those persistent PTSD to discuss deeply troubling events and restore control of their reactivity. How PTSD affects the quality of your life. Trauma impacts even the most resistant individuals among us and can include anything from separated occurrences, such as being alive after being somewhere with an active shooter in a public place, or narcissistic abuse in an intimate relationship, to serious and prolonged abuse or neglect occurring in childhood. Statistics suggest a lifetime estimate of around 6.8% for PTSD analysis, which is a small portion relative to the ones who experience trauma. Therefore, on average, approximately 7 out of 100 people will go on to develop symptoms associated with PTSD after experiencing a considerable terrible event, with an average estimate of 7.5 million to 8 million people each year developing the disorder. The results of post-traumatic tension can be long-lasting, chronic, and highly variable. Kids who are abused or overlooked might develop symptoms of PTSD or CPTSD, jeopardizing their ability to function as independent grown-ups. Others may not develop any symptoms or milder symptoms. Concerns with self-regard, self-love, feelings of uselessness, and self-destructive ideation are frequently reported in those PTSD or CPTSD. People who experience abuse in childhood are more prone to being re-traumatized later in life with unhealthy adult relationships. PTSD usually includes both short-term results immediately following a terrible event and more persistent long-term impacts. Whether someone will go on to develop PTSD or CPTSD following trauma is affected by many elements, which might include individual resiliency, character, previous history of trauma, severity or intensity of the trauma, or in other words, a one-time isolated event versus chronic or long-lasting abuse, period of the traumatic event or events, availability of an emotional support system, and other aspects such as environmental contingencies, such as drugs or alcohol, unstable or risky living conditions. Short-term or immediate results may include dissociation, psychological shock or pins and needles, shame, guilt, denial, confusion, rage and/or anger. Long-term effects are more variable and may include self-sabotaging conduct, fear of intimacy, concerns with body image, issues with self-esteem and self-regard, panic attacks, skin disorders such as persistent rashes, hives, or allergies, sadness, flashbacks, mental illness, hopelessness, sleep disorders or nightmares, anxiety or social phobias, headaches, drug or alcohol reliance or other self-medicating habits, autoimmune disorders, increased stimulation, memory problems, loss of trust in others, overall body aches and pain, repetition of generational trauma, fear of being alone, mentally or sexually manipulative intimate relationships, and food poisonings. Recuperating and growing. The most common treatment alternatives for substantial signs of PTSD or CPTSD typically include medication, EMDR or eye movement desensitization and reprocessing, and treatment. If signs are affecting your relationships or your capability to work in your life, it is essential that you seek help in moving past the trauma and its effects to help you grow once again. Dealing with the signs of PTSD or CPTSD can be devastating, affect your relationships, and adversely influence your life. Other things to consider for healing might include eating a healthy diet plan, making certain you are getting enough whole grains, fruits, and veggies to help promote a healthy immune system, which may help reduce intestinal or autoimmune issues. Limits. Healing needs developing limits, whether it is getting rid of unhealthy relationships or restricting how typically you choose to talk to your circle of loved ones. The people who care about your well-being will comprehend if you really need to take a little while alone for yourself. Participate in journaling. Writing your thoughts and feelings can be a great way to help better understand the connections between emotions, behavior, and environment while helping supply insight and personal awareness into your healing process. Self-awareness. Awareness is very important for understanding how you are feeling throughout your day and its influence on your behavior, your ideas, and your emotions. A journal might come in handy for being more lined up with ideas and emotions as they're being experienced, or with certain environments or activities that can trigger emotional flashbacks. Hang out in nature. Reconnecting with the simpleness of nature is extremely healing and therapeutic for many. Try a safe jog or a hike as a soothing strategy or to help enhance state of mind, feelings, and ideas. Disconnect. That may include disconnecting from people, spots, circumstances, or innovation while reconnecting with yourself and your own psychological needs. Restricting social networks or news, or skipping loud or congested spots may be useful to you during your healing journey. Chapter 3. The 4 possible subtypes of PTSD. Effective analytical tools advance our comprehension of critical issues. Precision medicine leverages technology and math tools to embellish care. Precision medicine techniques are on the cutting edge of medicine, and as such aren't always prepared for prime time. They are usually the topic of debate. Some physicians and patients are eager to try new things right away, while others prefer to wait to see if they work and if they trigger unanticipated negative reactions, also called bad effects. Design my care. Precision medicine includes developments like pharmacogenomics to assist in picking medications more than likely to work well without adverse effects, and neuroimaging to guide and direct treatment choice, for example, in determining whether psychiatric therapy or medications would be better to succeed for a given patient. Current research shows post-traumatic epigenetic changes are reversed by therapy. Functioning neuroimaging shows effective therapy stabilizes neural network activity in the brain as it reduces signs. Machine learning tools have been used to recognize different biologically based subtypes of depression, or biotypes. Researchers can scan the brains of suicidal patients using AI, which tries to discover who is more likely to harm themselves. These are just a few examples of how emerging tools can take our understanding of mental illness to a new level and start to inform treatment. Deep dive into trauma. The existing study used hidden class analysis with the National Epidemiological Study on Alcohol and Related Conditions, otherwise known as the NESARC-3. That study gathered information from a representative sample to show the general USA population. Of the over 36,000 individuals, practically 2,400 met requirements for PTSD at some point in their lives. Participants in this study finished a variety of steps looking at PTSD, sadness, anxiety, eating and personality disorder medical diagnoses, compound use of disorders, suicide efforts, current social stress factors or social instability, consisting of homelessness, unemployment, absence of medical insurance, and really need for public support, socio-demographic, information on ethnic background, salary, education, gender, and associated aspects, and general mental and physical health to evaluate lifestyle. Scientists found that a 4-factor model enabled the best data fit. The 4 subtypes of PTSD were 1. Dysphoric, 23.8%. Intrusive thoughts, avoidance of circumstances and thoughts associated with the trauma, negative thoughts and feelings, isolation, numbing and irritation, and trouble with sleep and concentration. They were more likely to be more youthful and male. They were less likely to have experienced fight. They were not as likely to get medication for PTSD. They were more likely to be detected with depression and less likely to be identified with anxiety. They were more likely to use nicotine. 2. Risk, 26.1%. Increased re-experiencing symptoms, high self-blame and negative emotion, lower levels of loss of interest, numbing, seclusion, and irritation, and high levels of physiologic stimulation or hyperarousal. They were more likely to be older and not as likely to have recent homelessness or joblessness. They were more likely to have personally experienced natural disasters and had health problems or injury to people near them. They were not as likely to report youth sex abuse as their worst trauma, and reported better mental health. They tended to have fewer additional psychiatric medical diagnoses. 3. High sign, 33.7%. Elevated levels of all symptoms except trauma-related amnesia and high-risk habits. They were more likely to be female, not as likely to be white, reported lower education and income levels, and were more likely to have current public help, homelessness, and joblessness. They were more likely to report fight and youth sex abuse as their worst trauma, were younger when they developed PTSD and had it longer, and reported even worse psychological and physical health. They were more likely to have gotten therapy and/or medication treatment for PTSD. They had higher rates of other psychiatric conditions, including anxiety conditions, bipolar illness, persistent sadness, cannabis and alcohol use disorders, and personality disorders, including borderline, schizotypal, and antisocial. This group most closely resembles CPTSD. 4. Low symptom, 16.3%. Lower levels of all signs except for intrusive thoughts, negative feelings, and hypervigilance. People in this group were more likely to have higher income levels. They were more likely to report the absolute worst trauma to somebody close to them instead of to themselves personally, and were not as likely to report personal war trauma. They tended to be older and have PTSD for a much shorter time, and to have better psychological and physical health. They were less likely to have received treatment with treatment and/or medications. They were less likely to have other psychiatric medical diagnoses, and not as likely to have character disorders. The future. While needing replication and elaboration, this research moves the needle for accuracy medicine by supplying a helpful structure for identifying different discussions of PTSD. It could enable a more refined method to avoidance and treatment, both for individual patients and clinicians. It is well worth noting that while some classifications had reasonably low signs, or in other words, lower dangerous behavior in the high symptom type contrasted with the others, this doesn't necessarily mean that those signs are at a normal level. Having a better sense of what we're dealing with on a fundamental level is an essential step. This work highlights the importance of the social determinants of health problems. While PTSD is an individual diagnosis, for high signs specifically, it is obvious that socioeconomic and related conditions matter factors for countless people. And for other subtypes, social factors appear to be protective. PTSD is not only a psychiatric diagnosis, it shows deep societal issues and plays out over generations. According to study authors, Drs. Trachik and Campbell, our research group is especially thinking about the precision medication aspect of this work. For future research, we are most interested in a treatment matching dataset to see if these typologies are associated with treatment outcome, dropout, or treatment adherence. It's our hope that given the dispute in the literature about the appropriate diagnostic meaning of PTSD, that the typology's work adds to discussions about the potential treatment considerations for those PTSD. Chapter 4. Dissociative Amnesia. Dissociative amnesia is just one of several dissociative conditions that psychologically separate an individual from some aspect of their self, often following trauma or extreme stress. In the case of dissociative amnesia, people are separated from their memories, suffering unusual amnesia in ways in which substantially disrupt their lives. They might forget a specific event, or they might forget who they are and everything about themselves and their personal history. The individual might or might not understand their amnesia, though they might appear puzzled. Unlike the ones who develop medical amnesia after an injury or stroke, however, somebody with dissociative amnesia seldom shows concern about their condition. It's approximated that 1.8% of American grown-ups experience dissociative amnesia in a given year. Signs. Dissociative amnesia is not typical forgetting, like misplacing secrets or forgetting the name of someone you met once or twice. Signs vary from forgetting personal information, like an individual's own name and address, to blocking out specific terrible events or even the events of a person's whole life. An individual with dissociative amnesia may not remember friends, members of the family, or colleagues. When an individual with generalized dissociative amnesia forgets every little thing about their self and their life, they might transfer to a new area and establish a new identity, but when discovered, they don't know how they arrived or why they have no identification. Most cases of dissociative amnesia are temporary, but memory spaces can last everywhere from several minutes to a whole lifetime. Those with dissociative amnesia might be at greater risk of self-injury and suicide. The DSM-5 includes the following symptoms for dissociative amnesia: the failure to remember crucial autobiographical info that one would generally be able to remember. The forgetting causes distress in everyday life, which includes at work, school, or with loved ones. The disruption isn't due to substance use, a different psychological health disorder, or any other health condition, such as a seizure or brain injury. Causes: past of recent trauma, abuse, mishaps, or extreme tension, like from a war or natural catastrophe, either observed or experienced, can cause dissociative amnesia. There might also be a genetic link, simply because people with dissociative conditions sometimes have family members with the same condition. While these signs might be similar, dissociative amnesia is not the same as amnesia resulting from brain disease or damage. Though, scientists have recognized unusual changes in brainwave activity in people with dissociative amnesia that could cause a better grasp of distressing memory loss and more reliable disorder-specific treatments. Treatment. While there are no evidence-based treatments particularly for dissociative amnesia, psychotherapy and other forms of treatment, like cognitive behavioral therapy and dialectical behavior therapy, are typically used to deal with the disorder. Strategies such as hypnosis and drug-assisted question and answer sessions may help spark the capability to retrieve memories, which can help clients understand how trauma may have triggered their amnesia, disrupted their life, and how to fix their concerns to help prevent more trauma in the future. Clients with anxiety or sadness can also take advantage of medications that target those conditions. Chapter 5. Comprehending Acute Stress Disorder versus PTSD. Severe stress disorder and PTSD are not fundamentally different. They are both reactions to a terrible experience, and they extremely closely share a symptomology. Yet the period of the disorders and the timing of their start do set them apart. These components of time have a bearing on an individual's diagnosis, but adequate treatment is critically important across the board for these trauma disorders. Whereas a severe stress disorder diagnosis can carry with it signs of dissociation, a PTSD diagnosis includes a dissociative subtype when these symptoms exist. Dissociative signs involve disconnection from the surrounding world or from oneself. That can feel for them as if time is slowing down, just as if they are out of their body, just as if they are watching life through a motion picture screen or in a daze. Their memory may also suffer, typically forgetting details of the terrible event itself. Because PTSD, by definition, lasts for longer than ASD, there is a value in determining those individuals experiencing dissociation who may really need improved mental care throughout their recovery journeys. The nature of the connection between ASD and PTSD doesn't really mean that all cases of acute stress disorder will eventually become trauma. Nor does it mean that all cases of PTSD always follow ASD. However, it is quite common for the two disorders to happen in sequence following an incidence of trauma. The value of treatment for terrible conditions. It is very possible that early attention and treatment for a person with ASD could help to prevent the ultimate start of PTSD. When somebody gets expert treatment, they can develop coping techniques before their disorder takes on a persistent hold. In other words, it is a mistake to dismiss acute stress disorder as normal distress that will just work itself out with time, simply because the extreme presence of the disorder shows that the person is having a hard time to process their terrible distress on their own. Disregard of either of these dangerous disorders can mean a pretty serious boost in the individual's distress, growth of their symptoms, and potentially the development of co-occurring mental health disorders like depression or substance abuse as a result. The sooner an individual gets treatment, the closer they are to the source of the trauma. The later a person gets treatment, the more they will have to wade through time and strong pain to recover their traumatic experiences, and the deeper the symptomology. The vulnerable and delicate nature of these conditions requires professional treatment from thoughtful specialists in intricate signs of traumatic disorders. At Bridges to Recovery, our knowledgeable physicians and psychotherapists can determine a client's complete and accurate analysis, as well as the holistic treatment plan for their optimal recovery path. The earlier they can connect with that path, the sooner their best life starts again. Chapter 6. Homeless Veterans Dealing with PTSD. It's hard to imagine someone who served our nation in the military living on the streets. Sadly, for many veterans, homelessness is a sad reality. Though there is no official count, The U.S. Department of Real Estate and Urban Development approximates that nearly 40,000 veterans are homeless. Trauma, PTSD, is considered a danger aspect for homelessness amongst veterans. The lifetime prevalence of PTSD amongst all United States grown-ups is approximated to be around 6.8%. Research suggests that this rate is much higher amongst veterans. As many as 30% of Vietnam veterans experience PTSD at some time during their lives. The lifetime prevalence is around 10.1% for veterans of the Gulf War, and the current frequency is around 13.8% for veterans of Operation Enduring Freedom and/or Operation Iraqi Liberty. These increased rates of PTSD amongst veterans might contribute in explaining why they are overrepresented in the United States homeless population. While veterans make up 9.7% of the overall population, they represent around 12.3% of the homeless population. What is PTSD? Living as a homeless veteran is hard enough. Add in the battles of PTSD, and it takes the circumstance to an entire different level. PTSD can affect anybody who has experienced a distressing circumstance, even if they're not in the military. Yet, simply because terrible circumstances can be prevalent in war zones, it influences military members disproportionately. PTSD activates an individual's fight or flight reaction in a circumstance that does not always require it. To be formally identified with PTSD, a veteran will experience the following symptoms for at the very least 1 month. At least one avoidance sign. Avoidance symptoms come from the impacted veteran wishing to stay away from places, events, or objects that remind them of the terrible experience, as well as keeping away from thoughts or feeling associated to it. So, a veteran may keep away from talking about war or may stay away from people who served in the military entirely, because being around other veterans brings back bad memories. At the very least, one re-experiencing sign. Re-experiencing signs are quite like they sound, flashbacks that include physical symptoms like sweating or elevated heart rate, bad dreams, and frightening thoughts. A veteran with PTSD might feel an instant threat even when no real danger exists. At least 2 cognitions and state of mind symptoms. Cognitions and mood signs mean that the affected individual has negative emotions, both about themselves and the world around them, emotions of guilt or blame, and has trouble recalling crucial parts of the event that caused PTSD. At least 2 arousal and reactivity signs. Arousal and reactivity symptoms, which are often continuous, include startling easily, feeling tense, sleeping problems, and having angry outbursts. PTSD is often accompanied by other mental disorders. Typical comorbid conditions include depression, anxiety, and drug abuse. Why veterans with PTSD become homeless? Researchers approximate that between 11 and 20% of veterans who served in Operation Iraqi Liberty or Operation Enduring Liberty struggle with PTSD. Furthermore, an estimated 12% of Gulf War veterans experience PTSD, while approximately 30% of Vietnam veterans have experienced PTSD in their lifetime. Lots of these veterans with PTSD didn't get adequate treatment to help them handle the traumatic events they witnessed in the armed force. Subsequently, they struggle to maintain jobs and have difficulty finding things in common with their loved ones. When veterans are discharged from the military, tons of them have a hard time to fit back in with the civilian life. Research shows veterans' absence of support and social isolation adds to homelessness among veterans with PTSD. A profile of homeless veterans. The VA approximates that approximately 11% of homeless people are veterans. Additionally, homeless veterans are almost completely male. Just 9% of homeless veterans are female. These veterans don't come from any one particular battle zone. Among them, homeless veterans served in wars varying from the Second World War to Vietnam to Afghanistan and Iraq, as well as in the Armed Forces anti-drug efforts in South America, says the National Coalition for Homeless Veterans, or NCHV. While PTSD has been connected with homelessness amongst veterans, however, one research study found that its impact was no greater than that of other psychological health conditions. So while PTSD is more typical in veterans than in the general population, it is not any more of a threat aspect for homelessness than other psychological conditions. Other risk aspects amongst veterans include other mental disorders, substance usage, distressing brain injuries, weak social support networks, low income, and joblessness. What's being done to help homeless veterans? Many individuals assume the VA and other federal government departments are taking care of veterans when they leave the armed force. The VA does have a specialized homelessness program for veterans that offers health care to nearly 150,000, while more than 40,000 homeless veterans receive some sort of month-to-month compensation or pension, notes the NCHV. Furthermore, the department has secured more than 45,000 beds for homeless veterans across the United States. This is an example. A joint program between the VA and the Department of Real Estate and Urban Development has rewarded more than 85,000 Section 8 real estate choice vouchers to public housing authorities across the nation since 2008. In 2012, the VA introduced the Encouraging Providers for Veteran Families, or SSVF, with the goal of both stopping homeless veterans and finding real estate for those that do experience homelessness. In 2015, this service helped more than 157,000 people, including but not limited to 99,000 veterans and 34,000 children, with just 9.4% returning to homelessness after benefits expired. That's why there are community-based companies that intend to meet the needs of homeless veterans, more than 2,100 of them across the country. The groups do what they can to work in cooperation with governmental companies, experienced service companies, and other homeless aid groups. NCHV notes that the most reliable programs are those that permit transitional real estate for the veteran that is both structured and substance-free, the ideal solution for all veterans struggling to return to a typical life. Chapter 7. Tension that comes from supporting someone with PTSD. The effect of post-traumatic stress disorder, or PTSD, can reach far past the individual with PTSD, impacting the lives of loved ones taking care of somebody with PTSD. How can you recognize and cope with this tension as a caregiver for a loved one with PTSD? Stress associated with support. Receiving support from others is very important throughout times of tension. Seeking support from another person is a healthy and effective way of handling a difficult event. Throughout times of stress, people typically turn to their loved ones initially for support. It is very important to understand that providing support requires energy and can be demanding. Watching a partner or spouse struggle with a problem can be disturbing and stressful. In most cases, it is possible to supply support without getting personally overwhelmed. However, when the stress is constant and support is frequently needed, caregiver burden may happen. What is caregiver burden? PTSD can be deemed a chronic health problem, and the person with PTSD might need continuous care from a loved one, such as a partner, parent, or another relative. Partners of people with PTSD might be confronted with some stress factors that accompany caring for and coping with somebody with a chronic illness. These stressors include financial pressure, managing the individual's symptoms, handling crises, the loss of friends, or the loss of intimacy. Due to a loved one's disease, partners might be the only people who can look after such stressors. This puts a huge burden on them, and subsequently, they may experience remarkable strain and stress, or caregiver burden. Studies on caregiver burden. Several research studies have looked at caregiver burden among partners caring for loved ones with PTSD. A quick conversation of two of these studies is provided below. In one research study, researchers looked at 154 partners of veterans with PTSD. They found that the intensity of the veteran's PTSD signs was linked to the amount of caregiver burden and distress experienced by the partner. Researchers have also looked at how PTSD signs such as depression, anger, and violence play out in relationships with PTSD clients and their caregivers. There may be a connection between how much detail about the trauma is shared with a partner, but more research is needed to better comprehend the issues. Studies taking a look at the partners of combat veterans have found that this tension can have damaging consequences emotionally. Among partners of battle veterans with PTSD, there was an increased risk not only of PTSD, but somatic illness, depression, panic attack, generalized anxiety disorder, and an increased level of self-destructive tendencies. Avoidance. It is important that caregivers have standard information about PTSD. Simply understanding the symptoms of PTSD and where they come from can help caregivers get a much better understanding of their loved one's analysis and behavior. Mental health experts recognize the tension that comes with looking after a loved one with PTSD. Caregivers might also benefit from attending individual therapy or support groups to find support for themselves and to learn how to cope better with their loved one's PTSD. Couples counseling may also be useful. Recently, online support groups have appeared, giving caregivers the opportunity to talk 24/7 with other caregivers of people with PTSD. As with any support group, it is essential to know that while a lot of these provide outstanding support, some groups can actually make you feel more depressed. If you choose to browse the web, make certain to get in touch with people who share your difficulties but support you in coping. How to cope. Regrettably, in spite of the significant impact of PTSD on family and friends, remarkably little research has taken a look at methods of helping caregivers deal with this tension. Moreover, the majority of the research is dated and concentrates on the occurrence of caregiver burden rather than any effort to look at ways of lowering the burden. Not only is the health of caregivers crucial and worthy of more research, but these caregivers are also the main source of support needed by those coping with PTSD. Until more is known, caregivers of people coping with PTSD may wish to look at ways in which caregivers of the ones with other conditions such as dementia and cancer have coped with their challenge. Final note on caring for a loved one with PTSD. Caregivers might feel guilty if they take time for themselves. However, it is very important for caregivers to realize that they too really need time to recharge their batteries. Dealing with and taking care of someone with PTSD is stressful. Unlike some conditions which are short-term, PTSD is a chronic condition that can feel unending sometimes. It's a marathon rather than a sprint, and as in a marathon, it's important for caregivers to pace themselves and require time to rest. The more a caregiver can learn how to look after themselves, the better they will have the ability to look after others. Some of these easy suggestions for caregivers of cancer clients pertain just as much to caregivers of people with PTSD. Hopefully, the stress influence on caregivers of people with PTSD will be studied more thoroughly in the near future, not just to record the presence of tension, but to look for ways in which caregivers can best cope. This has been PTSD, the brain of those with dissociative amnesia or acute stress disorder, by Jennifer Wartz. Narrated by Brandon Suku. PTSD, How to Overcome Trauma, Dissociative Disorders, and Grief, by Jennifer Wartz. Narrated by Brandon Suku. Chapter 1. The 7 reasons you still have PTSD symptoms. Are you struggling with symptoms like anxiety, hypervigilance, painful memories, terrible nightmares, depression, avoidance, and disgraceful ideas and feelings. These are a set of symptoms that can make life unhappy and might be brought on by post-traumatic stress disorder, or PTSD. Anyone can develop this complication following a traumatic event. There are many reasons that PTSD symptoms might continue gradually. Here are some possible reasons you or someone you care about may still be suffering. 1. You've tried therapy and it didn't work. Many well-meaning therapists have the ability to help somewhat with PTSD signs, but might not be trained in or using the most reliable techniques. Even so, in recent decades, the mental health field has almost refined some types of treatment that are shown to work. While they might not solve all of life's problems, repeated research programs they minimize the absolute worst of PTSD signs for many people, normally within 2 to 4 months. For grown-ups, these include cognitive processing therapy, extended direct exposure, and eye movement desensitization and reprocessing. 2. You tried several of the treatments from number 1 and it still didn't work. While these therapies, if properly provided, work for many people, there are always exceptions in any treatment. You may be an outlier, which just means different methods would work better for you. That is where alternative treatments become key, because everybody's brain is a bit different. You may try alternative approaches like expressive therapies, movement, or mindfulness practices, which we'll start checking out in this blog in coming weeks and months. 3. You don't have access to the treatment you really need. In some cases, it can be hard to find a therapist who is trained in these specialized approaches in your area. If you're having a hard time to find a qualified therapist, look for those positive in providing the therapies listed above. 4. Your trauma is current. It is pretty common to experience PTSD-like signs during or in the first several weeks following a traumatic memory. The majority of people don't develop complications beyond this point. That's why I don't instantly begin the treatments above with clients if they've just come out of a terrible experience. Rather, we build on natural coping skills and methods to help them make it all the way through this hard time, and stay away from negative coping that's shown to make things worse. If you have just experienced a traumatic memory, concentrate on resiliency methods like keeping in touch with your normal support system. 5. Avoidance is getting in your way. Did you know avoidance is one of the main categories of PTSD and typically what fuels it? While staying away from thoughts, memories, and feelings associating with bad things that took place seems to make sense and might even be necessary to get through a harmful time, in the long run, it actually makes things even worse. That is because you do not get to process and work through the thoughts and emotions that connect to what happened. And these ideas and emotions, even if they're deep down, develop in a myriad of ways and complicate PTSD. Sometimes we also stay away from circumstances that remind us of the trauma, or that otherwise feel out of control. Most also avoid treatment or drop out of treatment simply because it ends up being overwhelming. Again, all of this makes sense in context, yet can also be reinforcing symptoms. We'll also discuss more about avoiding in future posts. PE specifically targets avoidance, but other treatments also help you gain the self-confidence to deal with challenging but physically safe circumstances, ideas, and feelings. 6. The PTSD is making you be very hard on yourself. At times, people with PTSD blame themselves incorrectly for what happened, take on too much blame or embarrassment relating to the situation, or actually believe they're forever and ever harmed by the trauma. This can further be complex in a civilization that tends to blame victims for things like sexual assault. There's a lot more to check out here. While self-blaming thoughts are common and typical, they keep us from moving forward. One of the treatments I pointed out earlier, CPT, particularly targets these ideas that perpetuate PTSD. For many clients, this laser method works quickly, and if they stick with it for several weeks, they find relief. 7. You really need a medical diagnosis upgrade. If you've been detected with PTSD in the past, you may incorrectly really believe you still have it when there may be something else going on, such as general anxiety or a physical condition. Periodically, people might also get an inaccurate diagnosis in the first place. A skilled therapist or psychiatrist can help you sort through what's going on now. Even if you've struggled with PTSD for many months or years, it does not mean you need to accept these symptoms forever. Like with a physical problem, at times, you need to keep searching for a clinician, treatment, or alternative approach that is right for you. PTSD is a set of signs in reaction to a severe trauma. It is not something you were born with, and you don't have to live with it forever. Chapter 2. Sorrow. Grief is the acute pain that accompanies loss. Simply because it is a reflection of what we love, it can feel all-encompassing. Sorrow is not limited to the loss of people, but when it follows the loss of a loved one, it might be intensified by emotions of guilt and confusion, especially if the relationship was a tough one. The process of sorrow. Because grief obeys its own trajectory, there is no timetable for emotions of pain after loss. Nor is it possible to stay away from suffering altogether. Truth be told, tries to suppress or deny grief are just as likely to lengthen the process, while also demanding added psychological effort. Likewise, the misperception that more grief is better or that there is a proper way to grieve can make the process more difficult. For some people, sorrow is a short-term phenomenon, also referred to as severe sorrow, though the pain may return all of a sudden at a later time. But other people may experience extended sorrow, also known as complex grief, enduring months or years. Without help and support, such grief can result in isolation and persistent isolation. Supporting a griever. Because sorrow is experienced in many ways, experts suggest that those who would support a good friend or loved one in a time of grieving follow that person's lead and resist judging whether they appear to be insufficiently sad or to be dwelling in sorrow for too long. And it is typically unhelpful to encourage the pursuit of closure. Offering practical help and a recognition of a loss are both positive actions. Many mourners want those around them to listen, ask questions, and share memories, consequently verifying the depth and validity of the griever's emotions and helping them recover. What we mourn. It is expected that somebody will grieve after the loss of a parent, brother or sister, partner, kid, or buddy. However, those are not the only losses that cause sorrow. Many people might grieve the loss of a treasured pet, a job or other crucial role in life, or a house or other mentally significant possession. And it typically takes place after a divorce. Sadly, many find that those around them do not acknowledge these forms of grief, which is exactly why they are identified disenfranchised. The strong pain is intensified by the internal feeling that one has not been given consent to experience it. However, the framework of grieving can help an individual work through such moments of chaos, particularly if those around them respond with compassion and recognize that an individual is entitled to anger, numbness, and non-linear healing. Chapter 3. The Quest to Treat PTSD Better. For many with post-traumatic stress disorder, relief is evasive. But research determining the source of signs is spurring new restorative approaches. It may even be possible to stop PTSD before it begins. As a 21-year-old tank commander in the Israel Defense Forces, Yuval Neria saw comrades and close friends badly hurt and killed in the 1973 Yom Kippur War. He himself suffered serious injury when his tank was hit, but that didn't keep him from taking command of other tanks, for which he received the Medal of Valor, Israel's highest combat award. He served again in 1983. His experience on the Sinai Front in 1973 vividly informs Fire, a war novel he wrote that captures the terror, nerve, aggravation, and confusion of fight. It also decreed his life's work. The Yom Kippur War taught me a lot about the destructive effect of extreme combat, says Neria. I comprehended fear very well, extreme fear, fear for your life, he says. I knew a lot of people who ultimately developed PTSD. I felt really connected to them. I wanted to be included. He ended up being a scientific psychologist specializing in trauma, then a scientist probing his roots. In 2001, in the immediate wake of the World Trade Center attacks, New York's Columbia University recruited him to head its research and treatment program for PTSD. He saw it as a chance to follow what I would have felt was my destiny because of my experience in war. Neria never ever had post-traumatic stress disorder, but what I carry with me, in addition to the horror and the fear of war, is a comprehension of what clients are going through and a commitment to their treatment. War, of course, is not the only experience that stamps the brain so strongly that it remains constantly alert to threats, sees them where they might not exist, and gets memories of scared events so readily and vividly they overwhelm daily activities. Nor is it the sole catastrophe that shows up the emotional torture during the night, taunting sleep with the faces or weeps of kids or partners or comrades who could not be saved from harm. Fires, hurricanes, plane crashes, automobile accidents, sex abuse. Any unexpected, violent interruption, even a life-threatening disease like cancer, can leave a mark. And so Neria has carried out studies not only of veterans and prisoners of war and citizens under rocket attacks, but also of earthquake survivors, those who've endured sexual assault, people who lost loved ones on 9/11, and those straight exposed to the 9/11 attacks in New York City. At Columbia, Neria is focused mostly on the neural mechanisms underlying PTSD. His work highlights areas of the brain associated with recognizing threats and keeping memories of afraid events. Neria and colleagues have determined abnormalities in how these areas look, how they work, and particularly how they fail to work together. From his continuous studies, and those of many other scientists, efficient treatments are emerging. They target specific biochemical processes and brain circuits. Not all of the treatments are new. Direct exposure treatment, for instance, has been around for decades, but combined with targeted natural treatments including particular drugs and delivered in novel ways, it promises relief for the nearly 50% of patients left by present methods, their whiplash reactivity driving them to withdraw from the world, or to navigate it with suspicion or anger, or to numb themselves with compounds that exchange one sort of real pain for another. There's also great new hope that there are ways to prevent PTSD from ever taking place. 3 months, 3 years, or forever. The existence of PTSD was formally acknowledged in 1980, when it was first included in Psychiatry's Diagnostic and Statistical Handbook, then in its 3rd edition. The condition, however, has been around very likely since the first hunter was whipped by a lion, or the first trembler shook the earth. PTSD is a reaction to experiencing, or actually experiencing an event or series of events, involving the risk of death or serious bodily damage. People with PTSD suffer from timeless anxiety signs, like insomnia and worry, and are often hypervigilant, continuously alert to possible risks. They characteristically have an overstated startle response. Unforeseen noises, movements, or contact can provoke a strong, even violent response. PTSD is defined by intrusive memories, the distressing event or events is remembered spontaneously in flashbacks, with the same panic, fear, and terror it originally evoked. Traumatic moods and ideas persist. They can take the form of anger, guilt, shame, or a feeling of detachment from others. Ideas like absolutely nothing good can happen to me and nobody can be trusted are common. To evade reminders of the trauma, patients may stay away from leaving the house. The disorder is not simply fear-based, worries psychologist Paula Schnurr, executive director of the National Center for PTSD, a unit of the Veterans Administration. It can show up as sadness, complete with shame, guilt, and apathy, or as anger and hostility. The inside story of PTSD. When sensory areas of the brain discover a prospective danger, nerve impulses are instantly routed through the thalamus to the amygdala. Aroused, the amygdala generates the experience of fear and indicates the adrenaline glands to produce adrenaline, raising heart rate and high blood pressure to set in motion the body for sudden action. For more continual mobilization, the hypothalamic pituitary turning point swings into equipment, tripping off a waterfall of body hormones, culminating in the release of cortisol, which extends the mobilization reaction. It also keeps the amygdala activated, keeping the state of high alert. In such an aroused state, strong memories are readily formed, and they have staying power. Under typical conditions, the thinking brain breaks amygdala activation, bringing mobilization to a halt when it concludes that threat is past, and the hippocampus puts the episode in the setting of past experience. With PTSD, people stay hypervigilant, on the lookout for danger even in everyday scenarios. Fear memories are easily awakened. Common sounds, sights, and even ideas trigger recollection of the terrible event so clearly that it feels just as if it is happening again. Armand Cuciniello III was a diplomat at the United States Embassy in Baghdad throughout the Iraq War, living and operating in the Green Zone, a compound secured by tall concrete walls topped by barbed wire. But rockets and mortars lobbed or fired overhead had no issue permeating it, recalls Cuciniello. Attacks began during the troop rise of spring 2007, 6 months after he showed up. My first exposure was the worst. I heard a woman die just meters away. There was no pattern to the attacks. You never ever knew what would happen or when. After a year of off and on bombardment, I was extremely tense, highly emotional. I would well up just as though I wanted to cry, for no reason, Cuciniello recalls. A psychiatrist told him he had PTSD and prescribed an antidepressant. The drug helped his emotional control, but even years later, loud noises, doors slamming, anything like a boom would activate me. Time would stop for a few seconds, and I would be incapacitated, he says. On a checkout to family in New York City, the dull thump of a taxi discussing an iron plate covering street building in construction, not loud, but the specific pitch of a rocket taking off, could provoke a flashback. He had trouble sleeping for several years, and even now, if he tries going off his medication, every little thing comes back, the tense feeling, the welling up of tears. Cuciniello has happened with his life and is now an advisor to 4-star Army General Robert Adams, who heads the United States Command in South Korea. There's been a great rise of interest in biological markers that identify the changes brought on by PTSD, and that could be used to anticipate and diagnose the disorder, Schnurr reports. With brain imaging tools like magnetic resonance imaging, scientists are getting a dynamic picture of the flashback memories, the fear, and other state-of-mind disturbances common of the disorder. The National Center now also preserves a brain bank, a repository of post-mortem tissue samples from PTSD victims to facilitate investigation into the molecular machinery giving life to the symptoms. We see at the very least 3 areas included, Neary reports. They include the amygdala, which regulates feeling and is ground zero for processing fear, the hippocampus, where memories are processed for storage and retrieval, and areas of the prefrontal cortex, the planning and choice center of the brain, which generally has the capacity to moisten amygdala activity. In the wake of a traumatic event, he says, circuits of communication amongst the 3 regions are interrupted, accounting for the harmful vitality of traumatic memory. In PTSD, the amygdala is hyperactivated and the prefrontal cortex and hippocampus are underengaged, leaving patients extremely restless and haunted by their distressing experiences, the memories appearing and reappearing involuntarily, with a strength unblemished by time. Attempting to acquire power over those memories and their associated anxiety, nightmares, and flashbacks, we see a lot of avoidance. People stay away from talking about their trauma, attempting to manage their anxiety level, says Neary. They avoid situations that might trigger recollection. Numbing of emotion comes later. Clients end up being more depressed than excited. 50% of people with PTSD, in fact, also experience depression. Neurobiologist Benjamin Suarez Jimenez, a member of Neary's laboratory, employs virtual reality to explore the tendency to see threat where there is none. While in an MRI scanner, subjects video walk through a meadow selecting flowers. In some areas, they are stung by bees, represented by mild electric shocks. In others, they are not. Healthy controls learn to distinguish between safe and hazardous areas, becoming hyper-aroused only in areas where they were stung. Most people with PTSD overgeneralize. They don't discriminate accurately between safe and threatening parts, Suarez Jimenez finds. He is trying to pinpoint the brain parts accountable for the overgeneralization of danger. In earlier work, he identified the brain networks activated when healthy subjects make safe, dangerous differences, and is now collecting information on PTSD clients. We want to compare brain activity, physiology, and self-ratings of anxiety in people who have never experienced extreme trauma, those who have and developed PTSD, and those who were resilient. Although most brain imaging work offers essential insights, some findings have direct scientific application. Some studies in his laboratory and in other places suggest that the size of the hippocampus is an essential to response to treatment, says Neary. We found that clients who have a bigger hippocampus develop less PTSD over time and do better. Tests revealing a small hippocampus may well indicate the need for medication and psychotherapy focused on reprocessing their memories. Psychotherapy contributed for Philip Robinson. Being a survivor is rather challenging, says Robinson, who, 30 years ago last August, started the streamer Margianas, in addition to 130 others, most in their 20s, to celebrate the birthday of a London good friend. He was beneath deck when a substantial barge riding high in the Thames essentially ran over the boat and sent it down in seconds. I was struck in the shoulder and hit by flying bottles. I just swam and swam. I'm a professional vocalist, and I kept hold of my breath. I got out through a broken window. 51 others didn't. And Robinson did well until, 11 years after the catastrophe, a public query got underway. We had to relive the accident. There were interviews, investigations. My relationship broke down. I was having trouble at work. A checkout to his GP resulted in a full psychiatric assessment. I was experiencing sadness. My typically robust coping systems had been challenged and overwhelmed. 2 years of work with a therapist followed. He was motivated to let go of the belief that I was singing for my dead friends. He now sings for himself. Singing is a manner in which my soul can speak with tragedy. Because Robinson is the first to acknowledge how luckily the aspects of his life worked for him, he set up a charity to help other victims of single-incident disasters get whatever help they found to really need. Every year, his charity, the Antonio Vasconcelos Fund, gives out 51 grants, each in the name of a Marchianas victim. The stricken and the spared. Not everybody exposed to disastrous or deadly events develops PTSD. Even among veterans of battle, which can deliver a barrage of troubling events under conditions of high emotional stimulation, rates of the disorder vary from 10 to 30%. Researchers have been dissecting precisely what makes up strength since the late sociologist Emmy Werner started tracking the development of each baby born upon the island of Kauai in 1955 and discovered that only a minority of those delivered into highly unfavorable circumstances end up struggling or in trouble. For the most part, says psychiatrist Adriana Feder of New York's Mount Sinai Medical Center, strength research has sought answers in psychosocial elements like family stability and social support, which foster emotional regulation. Only just recently has it deepened to include biology. Most research into precisely what goes awry in tension circuitry in PTSD looks at people who already have the disorder. However, the most beneficial studies, Feder observes, would look at people before they experience trauma, like Army personnel pre-deployment and people starting work in cops and fire departments, and follow them. A pretty big country collective study named Aurora is doing the next best thing. Scientists are gathering data, which includes brain scans, on people seen in emergency rooms instantly after trauma direct exposure and looking for patterns of brain activity that forecast how they fare with time. Feder herself is leading research studies of cops, building workers, and others who reacted to the World Trade Center attacks, comparing the ones that went on to develop PTSD with those that did not. The 9/11 attacks, as terrible as they were, are working as a living lab lighting up the natural course of PTSD. Overall, research studies show, among people exposed to the trauma, PTSD rates declined over the first few years. Volunteer first responders were significantly more likely to develop PTSD than experts, such as police and firefighters. Volunteers not associated with rescue companies like the Red Cross were especially hard hit, with PTSD rates of nearly 30% versus 13% for the pros. Those data validate earlier findings. Individuals with a history of trauma direct exposure or mental problems, and the ones with poor social support and recent or continuous life stress are at high risk of PTSD. An important new finding was that physical impairment or job loss raised the risk of PTSD. Psychotherapy, including but not limited to exposure treatments utilizing virtual reality, was generally reliable. New data found that children reacted well to psychological therapy provided in school or the community. IMAGINE is the acronym for a pretty large European study tracking how a wide variety of factors throughout teenage years influences brain development and adult mental health. One of the findings so far is that teenagers who are doing well, regardless of the presence of major stressors in their life, react in a distinctive way when shown images of afraid or angry faces, normally a stress-including circumstance. Especially, there is little activation of the amygdala. Moreover, research studies show that these youth have more gray matter in the prefrontal cortex, circuitry associated with cognitive reappraisal. The ability to interpret an event's meaning appears associated with more controlled, less excessive reactions. Can durability be cultivated? Stress inoculation treatment, usually a component of cognitive behavioral therapy, depends on it. It aims to strengthen people in advance of challenging experiences by exposing them to a development of difficult situations through imagery and video stimulations. It seeks to help people develop coping skills, to maintain cognitive flexibility so that troubles can be viewed as challenges to be mastered and chances for development, and to instill a sense of control, the awareness that it's possible to shape the stress reaction by such perceptions. The treatment is often used with people who will be exposed to battle. It may be that specific drugs given to people instantly before exposure to life-threatening conditions, or instantly after, can also avert development of PTSD. Among the representatives under study is neuropeptide Y, or NPY, a chemical found throughout the nervous system and best understood for promoting food intake. In the brain, NPY is also associated with resilience to the damaging effects of stress, says neuroscientist Esther Sabin of New York City Medical College. There is some proof that NPY is an all-around inhibitor of nerve action, so it takes a more powerful dose of danger to overactivate stress circuit nerve cells and dysregulate them. In the amygdala, its release silences the response to stress. Studies show that people with PTSD have lower blood levels of neuropeptide Y than those who don't develop PTSD. It is unrealistic to know yet whether the distinction precedes their reaction to trauma or is a result of it, although genetic studies suggest it is pre-existing. In one of her own experiments, performed on rats, Sabin and associates subjected animals to a strong and extended stressor, the rodent equivalent of trauma. Animals got NPY either 30 minutes before the tension direct exposure, immediately after it, or a week later, when serious stress effects had already set in. NPY given before or instantly after direct exposure to stress entirely blocked development of PTSD-like responses. It had no impact on full-blown symptoms. Human research studies with NPY are few. One small medical trial found that the neuropeptide given intransitally, or to go directly to the brain, averting unwanted impacts on the body, minimized the anxiety symptoms of PTSD. Sabin and her associates are now conducting research that, she hopes, will result in medical trial big enough to establish whether giving the drug within 2 days after trauma can prevent development of distress to PTSD. The reverse of stress. NPY isn't the only chemical hope against PTSD. Compounds of interest include ketamine, an anesthetic that has a shady past as a club drug called Unique K, but which has recently been approved for use to treat extreme, constant sadness, specifically when joined by ideas of suicide. Delivered intravenously, it acts quickly, within hours, although nobody knows exactly how. After years of testing, esketamine, one of 2 nearly similar forms of ketamine, was FDA approved for resistant sadness early this year. A couple of patients we dealt with for depression had PTSD, and their signs appeared to get a lot better too, Adriana Feder reports. This resulted in our first study in 2014 with a single intravenous infusion of ketamine. Treatment led to improvement in all symptom groups of PTSD, re-experiencing the distressing occurrence, avoidance, anhedonia, and hyperarousal, measured 24 hours later. Feder is now leading a medical trial in which clients get 6 doses of the drug over a 2-week period to see whether we can replicate these preliminary findings and maintain the response. There are strong indicators that ketamine fundamentally alters nerve connection within the brain. We published a neuroimaging study in depressed patients, which found increased connectivity in emotional control areas after ketamine administration, Feder reports. Her group is now carrying out a similar study in clients with PTSD. Neuroscientist Ronald Duman, professor of psychiatry and director of molecular psychiatry at Yale University, contends that PTSD is fundamentally a synaptic deficit disorder, blunting communication between individual nerve cells. A lot of brain imaging work demonstrates reduced volume in brain regions implicated in PTSD. That led to the idea that a loss of synaptic connections could be involved. A scarcity of connections between afferent neuron would compromise neuroplasticity, hindering learning and keeping those exposed to trauma stuck in their excessive reaction, without any neural escape path, no pathway for extinguishing the fear response. Animal research has revealed that synapses in the hippocampus and prefrontal cortex dwindle after chronic tension. But proof that the exact same thing happens in PTSD has been elusive. These are technically very hard studies to do, Duman observes. There's some indirect evidence of synaptic loss in humans with PTSD. In studies of tissue samples from the PTSD Center's brain bank, scientists have found distinctions in genes regulating synapse formation between individuals with PTSD and those without. The findings, if validated, could help explain how ketamine works, both in sadness and PTSD. Ketamine produces an impact opposite to stress. It increases synaptic connection in the prefrontal cortex even after a single dose, Duman says. Synaptic plasticity, the growth of new interneuron connections, is the foundation of memory and learning. And, in its unraveling, it is the source of the memory-changing procedures that go awry in PTSD. Normally, the link between a memory and the emotions connected with it can be snuffed out. In time, the emotional reaction element weakens and dissipates. What's more, researchers know that every time a memory is evoked, it can be modified and reframed, a procedure known as reconsolidation. That leads the way for talking about a bad experience with friends in enjoyable surroundings to send the memory back into storage in less disturbing forms. But in PTSD, memories withstand both kinds of change, making them nearly ineradicable. The memory is always saved in its original form, they're being raped again, with all of the emotions of the original event, clarifies scientific psychologist Ian Harpis-Rodham, also of Yale. Extended direct exposure and cognitive reappraisal are known to be two of the most effective psychotherapies. They work by advancing memory modification, the very process paralyzed by PTSD. Patients need a nudge, and enhanced neurogenesis after ketamine might open a window of reconsolidation, says Harpis-Rodham. The Yale researcher is preparing to provide that push, with a clinical trial that integrates ketamine with prolonged exposure therapy. The combination could do it in 7 days what, under the best of situations, might otherwise take months. Before and after MRI research studies will explore whether and how the treatment changes the way parts of the brain interact. That's one possibility, the rapid-acting way. If Ronald Duman is right, there are other ways to restore synaptic connection and mental flexibility. Prime amongst them is exercise, which is known to straight stimulate the growth of new neuronal connections. Perhaps a door. Paula Schnurr is thrilled about the use of ketamine to potentiate and enhance the power of the most efficient psychotherapy. It's a circumstance of taking something that works well and making it work even better. Another chemical agent that fits that cost is the psychedelic drug MDMA, aka ecstasy. It catalyzes the psychotherapeutic process, says psychiatrist Michael Mithofer, who has led 20 years of research on MDMA. Extreme interest in its potential has spurred the FDA to designate MDMA an advancement treatment for PTSD, and the agency is fast-tracking it towards approval. MDMA is already authorized for use in Israel. A global Stage 3 scientific trial, a huge step to approval, is already underway. An analysis of 6 small clinical trials showed that the representative caused sign enhancement double that of control groups. In the basic protocol, patients are given MDMA before each of 3 treatment sessions of 8 hours or longer, performed by 2 specifically trained therapists and spaced a week apart. We don't tell people to discuss trauma, but whatever comes up, says Mithover. Unstructured as these sessions are, components of standard trauma treatment, exposure to traumatic material, and cognitive restructuring are typically engaged. We stress that MDMA is very different from most psychiatric medications in that it is not developed to quench signs, but to help process underlying causes. At times, signs get worse before they get much better. As a neuroscientist looking into trauma for 3 decades, psychologist Rachel Yehuda was hesitant of MDMA case reports. Having actually been in the field for so long and having research experience with many treatments, I could not fathom the claim that after a couple of sessions, people with persistent PTSD no longer had it, says Yehuda, director of the Distressing Tension Research Studies at Mount Sinai Medical Center. That was before she went to Israel. I started to understand this was a technique to trauma therapy that involves inducing a really safe and cocooned state for a person. The drug, she says, produces an open, warm feeling of self-compassion, and the therapist provides an environment for understanding the material that is showing up, making it safe to see from different angles. It removes the barriers where people normally get stuck in psychotherapy, where it hurts the core where they do not want to go. Yehuda herself underwent a session of treatment, which she says gave her a within comprehension of how the accelerated psychotherapeutic experience cultivates accessing and processing the events of one's life. It's like learning you can take a plane from New York to Los Angeles instead of having to walk there. Those of us who have tried to comprehend trauma have been searching for a window to help people, Yehuda says. This may be a floor-to-ceiling window, perhaps a door. We know that MDMA reduces activity in the amygdala and increases it in the prefrontal cortex, which fits truly well with what we see clinically. People can unexpectedly speak about their trauma without being gotten rid of by feeling, Mithover says. A veterinarian who went through treatment said, Iraq changed my brain, and MDMA changed it back. There is brain imaging data to show that. Regaining control of their own brains. All the imaging studies checking out the neurobiology of PTSD have helped determine which brain areas need to be turned up and which denied, says Paul Holtzheimer, Deputy Director for Research at the National Center for PTSD. And that opens the way for highly targeted treatments, including neurofeedback. When you fear something, the amygdala ends up being triggered. In PTSD, it is triggered more, says Ian Harpis-Rotem. With neurofeedback, patients learn how to minimize signs by calling back brain activity by themselves. Particularly after being at the mercy of unforeseeable triggers anytime and anywhere, it's empowering for them to take control of their own brains, he says. Harpis-Rotem is leading a clinical trial in which individuals with PTSD lie in an MRI scanner, watching a guideline that tracks blood flow, an indication of amygdala activity, while they are to read a script and hear noises evocative of the speeding up trauma. They are taught techniques to lower fear and, by watching the guideline, can figure out which ones moisten amygdala stimulation. The hope is that they will use these strategies whenever they feel overwhelmed, not to eliminate the memories, but to learn to tolerate them, he says. Before and after MRIs will reveal any transformed connection between the amygdala, the hippocampus, and the prefrontal cortex and any connections with sign reduction. Another promising treatment takes direct focus on the malfunctioning circuitry of PTSD and gives it a reboot. Transcranial magnetic stimulation, which applies a shifting electromagnetic field to produce small electric currents in pertinent areas, is already in usage for drug-resistant depression and obsessive-compulsive disorder. In PTSD, it targets an essential neural node, the dorsolateral prefrontal cortex. The objective is to boost cognitive control so the brain can better regulate feeling, decreasing the intensity of undesirable experiences. The effects might roll over to certain symptoms, avoidance, even flashbacks, says Holzheimer. Brain stimulation is being tested as a psychotherapy booster too. Applied just prior to weekly sessions of cognitive reprocessing therapy, the treatment, Holzheimer worries, is still very much an operation in progress. If it follows the same timeline as that for sadness, perhaps in 5 years we will see a pivotal scientific trial that opens the door to broad availability. The capability to treat PTSD efficiently is advancing in lockstep with new comprehension of the disorder. Horrible events will continue to happen. Even if war were to stop tomorrow, nature provides its own random blows. Emotional aftershocks will inevitably resound in the minds and brains of those exposed. However, while pain is inescapable, enduring suffering is not. Putting an end to it is no longer a difficult goal. Chapter 4. Dissociation. How people manage trauma they want to forget. When you witness or experience something awful, you might try not to think about it. To help you, your brain might contact one of its most creative and ingenious coping techniques to keep you going: dissociation. In the easiest terms, dissociation is a mental block between your awareness and parts of your world that feel too scary to know. Dissociation happens to almost everyone at a little bit of time. It takes several forms for different people. But for people with a complicated trauma history, dissociation keeps the brain in survival mode. No one can endure a continuous state of fear and still function well. You cannot make it through life unscathed while always feeling frozen, anxious, or shut down by your greatest fears. Dissociation can operate as security by keeping people unaware of the distress of being traumatized. That's when it can ultimately trigger problems for people who have been hurt extremely badly, particularly as kids. Children are specifically very likely to use dissociation to manage the inescapable pain of family problems that lead to complex, developing, and relational trauma. Such issues can include continuous abuse, disregard or disorganized, avoidant or insecure attachment. Children should do something to endure experiences that make them feel hazardous. They cope by being detached to the memories, emotions, and body sensations that are too much to bear. On the outside, they might look okay. However, consistent dissociation as a means of defense or survival for years then follows them into adult life, where it doesn't work so well. As a coping mechanism, dissociation typically disrupts the life a person wants to have when the abuse is no longer continuous in the present. When dissociation blocks awareness of real pain, it can also obscure the path to healing. So let's take a close look at dissociation as a coping mechanism for trauma survivors. If we can securely see where it comes from and how it evolves, we can also see what healing looks like. What is dissociation? Dissociation is a state of disconnection from the here and now. When people are dissociating, they are less conscious or unaware of their environments or inner sensations. Decreased awareness is one way to deal with triggers in the environment or from memories that would otherwise reawaken a sense of immediate risk. Triggers are reminded of unhealed trauma and associated strong emotions such as panic and fear. Blocking awareness of experiences is a way to keep away from possible triggers, which secures against the risk of being flooded by emotions like fear, anxiety, and shame. Dissociation allows you to stop feeling. Dissociation can happen during an experience which is overwhelming and which you can't leave, causing trauma, or later on when thinking about or being reminded of the trauma. Dissociation is a coping system allowing a person to work in daily life by continuing to stay away from being overwhelmed by extremely demanding experiences, both in the past and present. Even if the hazard has passed, your brain still says risk. Unprocessed, these fears might stop you from living the life you want or changing unhelpful behaviors as you grow. Some level of dissociation is typical. All of us do it. For example, when we get to work and have to leave the personal concerns behind, we choose to put them out of mind for a while. However, when dissociation is learned as a coping method, specifically in childhood for survival purposes, it rolls over into their adult years as an automatic response, not a choice. Kids with trauma are more likely to experience dissociation. As a protective method for handling trauma, dissociation can be one of the most creative survival skills a severe trauma survivor refines. It removes consciousness from a person's environments, body feelings, and feelings. Children who experience complicated trauma are particularly very likely to develop dissociation. It often co-occurs with the earliest incidents of recurrent trauma, since the only way to make it through the dreadful experiences emotionally is to not be there knowingly. There are many possible conditions that trigger dissociation. Therapists understand and focus their grasp of dissociation in connection with the underlying trauma, what happened to you. Some basic examples of risk elements for dissociation are a messy attachment style. Trauma inflicted by abuse from a primary attachment figure for primary school-age children can cause dissociative conditions for the kid. When someone the kid depends on for survival is also a source of physical, sexual, or psychological abuse, a protective reaction is to leave existing in their body to endure the abuse, while preserving the needed family tie or even their life. An insecure attachment style. A child consciously develops habits or habits to dissociate, like using loud music, so they do not hear frightening arguments between parents that frighten, for example. They might turn to computer games or other diversions while father paces the floor worried because mom is out drinking. Recurrent abuse or disregard that threatens a sense of safety and survival of any kind by anybody. Post-traumatic stress disorder, or PTSD, and complicated PTSD, or CPTSD. Dissociation to deal with events that cause PTSD or CPTSD, developmental, relational, or continuous trauma, can include out-of-body responses to trauma. A neurological reaction causes some trauma survivors to dissociate to a level where they look out at their bodies from another perspective. This can be looking down from above or looking at a part of their body that doesn't appear to come from them. Dissociation occurs on a continuum, typically impacted by just how long or typically one relies on it, whether the person has any other coping methods, or whether other trusted helpers or a safe space is readily available. Helpers or places where the child feels safe and secure can provide a way to safely be linked to emotions, experiences, and body, despite the overwhelm somewhere else. Youth dissociation continues through their adult years. As children with trauma age, they may use self-harm, food, drugs, alcohol, or any other coping system to maintain the disconnection from unhealed trauma. As therapists, we see these habits serving two functions for trauma survivors. As a dissociative system or way to dissociate, for example, using alcohol or drugs to physically disconnect them from their thinking brain. As a way to sustain habits that keep them dissociated. I'm not connected to my body, so I can cut without pain. Or I'm not linked to my body, so I do not notice that I am full and do not really need more food to consume. Eventually, this coping method that was useful in youth and their adult years compromises capabilities to trust, attach, socialize, and offer good self-care. Those challenges follow trauma survivors throughout their life, if not addressed. Recognizing dissociation in adults. Grown-ups do not just grow out of dissociation learned as a youth coping skill. It likely becomes a go-to coping mechanism for preserving life. Adults might not be aware of their continuous state of dissociation, while words and actions like these tell a much different story. Somebody tells a therapist their most distressing experiences without understanding or trusting them first, and does so without feeling linked to the story. They are speaking from a dissociated place. Somebody uses drugs, alcohol, cutting, food, porn, or other forms of self-injurious conduct to continue to dissociate and not be present with their emotions. Somebody disconnects from the here and now when they're activated by a certain circumstance or even a fragrance, such as cologne, and find themselves inside a flashback which feels very real. A veteran hears a noise that triggers a flashback to a wartime event. Someone is arguing with their partner, but when their partner shouts, they take a look at. Dissociation is at times the best way an individual can survive a terrifying experience in the moment, or chronic developmental trauma over several years. Yet it actually ends up being an issue, an obstruction, in adult life. Dissociation hinders forming safe and secure relationships and connections. Dissociation can prevent you from developing these relationships or being present for them. The reality is, in your adult life, you might actually be more secure today learning to see, reconnect, and reintegrate the dissociated parts. Maybe you are really safe now and do not need this coping system to safeguard you any longer. Most times, a person will appear in therapy for some other reason besides the use of dissociation and even trauma. They are there because they feel miserable, or are drinking too much, or fighting with their partner. They can't figure out why these problems continue, as they have a great life now. As trauma-informed therapists, we can help people safely discover what problems are showing up as a result of their past history. We can help them find and see what made sense at the time given what was going on in their life that they had to survive. We can help people comprehend they're not bad and something is not wrong with them. Their concerns are based on the dissociative survival skills they learned in childhood to survive, which were very useful at the time, but not any longer. Chapter 5. What are dissociative disorders? Dissociative disorders involve issues with memory, identity, emotion, perception, behavior, and sense of self. Dissociative symptoms can potentially disrupt every area of mental functioning. Examples of dissociative symptoms include the experience of detachment or feeling just as if one is outside one's body, and loss of memory or amnesia. Dissociative conditions are often related to previous experience of trauma. There are 3 kinds of dissociative disorders: dissociative identity disorder, dissociative amnesia, depersonalization or derealization disorder. The Sidran Institute, which works to help people comprehend and handle traumatic stress and dissociative disorders, describes the phenomenon of dissociation and the purpose it may act as follows. Dissociation is a disconnection between a person's ideas, memories, feelings, actions, or sense of who he or she is. That is a normal process that everyone has experienced. Examples of moderate, typical dissociation include daydreaming, highway hypnosis, or getting lost in a book or movie, all of which include losing touch with awareness of an individual's instant surroundings. During a distressing experience such as a mishap, catastrophe, or criminal offense victimization, dissociation can help an individual endure what may otherwise be too challenging to bear. In circumstances like these, a person might dissociate the memory of the place, scenarios, or emotions about the frustrating event, mentally escaping from the fear, real pain, and horror. that might make it challenging to later remember the details of the experience, as reported by many catastrophe and accident survivors. Dissociative identity disorder. Dissociative identity disorder is connected with frustrating experiences, traumatic events, and/or abuse that took place in childhood. Dissociative identity disorder was previously described as split personality disorder. Symptoms of dissociative identity disorder, criteria for analysis, include the existence of two or more distinct identities or personality states. The distinct identities are accompanied by changes in behavior, memory, and thinking. The signs and symptoms might be observed by others or reported by the individual. Continuous spaces in memory about daily events, personal info, and/or past traumatic events. These symptoms cause considerable distress or issues in social, occupational, or other areas of functioning. In addition, the disturbance must not be a regular part of a broadly accepted cultural or religious practice. As noted in the DSM-51, in many cultures all over the world, experiences of being had are a normal part of spiritual practice and aren't dissociative disorders. The mindset and personal preferences, for instance about food, activities, or clothes, of a person with dissociative identity disorder may all of a sudden move and after that move back. The identities happen involuntarily and are undesirable and trigger distress. Many people with dissociative identity disorder may feel that they have unexpectedly become observers of their own speech and actions, or their bodies might feel different, like a little kid, like the opposite gender, big and muscular. The Sidran Institute notes that an individual with dissociative identity disorder feels as though she has within her two or more beings, each with its own way of thinking and remembering about herself and her life. It is very important to bear in mind that though these alternate states may feel or seem extremely different, they are all symptoms of a single, whole individual. Other names used to specify these alternate states include alternate characters, changes, states of awareness, and identities. For people with dissociative identity disorder, the degrees of problems functioning can vary widely, from minimal to significant issues. Most people usually try to lessen the impact of their symptoms. Risk aspects and suicide risk. People who have experienced physical and sex abuse in youth are at an increased risk of dissociative identity disorder. The huge bulk of people who develop dissociative conditions have experienced repeated, overwhelming trauma in childhood. Amongst people with dissociative identity disorder in the United States, Canada, and Europe, about 90% had been the victims of childhood abuse and disregard. Suicide efforts and other self-injurious conduct are really common amongst people with dissociative identity disorder. More than 70% of outpatients with dissociative identity disorder have attempted suicide. Treatment. With appropriate treatment, lots of people achieve success in dealing with the significant signs of dissociative identity disorder and improving their ability to function and live an efficient, fulfilling life. Treatment typically includes psychotherapy. Treatment can help people gain control over the dissociative process and signs. The objective of treatment is to help integrate the different components of identity. Treatment might be extreme and tough, as it involves remembering and managing past terrible experiences. Cognitive behavioral therapy and dialectical behavioral therapy are two commonly used kinds of therapy. Hypnosis has also been found to be valuable in treatment of dissociative identity disorder. There are no medications to directly treat the signs of dissociative identity disorder, though medication may be helpful in dealing with related conditions or symptoms, such as the use of antidepressants to deal with signs of sadness. This has been PTSD: How to Overcome Trauma, Dissociative Disorders, and Grief by Jennifer Wartz. Narrated by Brandon Suku. PTSD, How to Handle Trauma in Marriage and Survivor's Guilt by Jennifer Wards. Narrated by Brandon Suku. Chapter 1. How to Handle PTSD. As most of us understand, mass shootings and violent acts of intolerance have increased in the last few years. While political leaders and pundits try, mostly ineffectually, to clarify these events, we're left reeling from the rapidity of one dreadful nationwide trauma to the next. But we can resolve how our natural curiosity for additional information, the whos, whats, whys, and wheres of each incident, is rapidly capitalized on by the media as their videos are placed in an endless loop on each news source. They continue with their mantra, if it bleeds, it leads. That means violence is attention-getting, and showing it up close usually gets more viewers, which gets higher scores, which gets more marketing dollars on those media channels. While an increased awareness of the violence that pesters our nation is essential, it can also leave us feeling anxious and depressed. Secondary PTSD. After 9/11, the medical community steadfastly determined it is possible to experience PTSD not only by belonging to the event, but also by seeing or finding out about a traumatic event that is distant from a person's home base. This form of PTSD is called secondary PTSD and was given the attention of psychological health professionals when they noted that wives and kids of Vietnam War veterans suffering from PTSD also displayed PTSD symptoms. With this knowledge, how can we not be affected by the barrage of details and also the realization that these PTSD-making events are taking place on an increasingly regular basis? The answer is, we can't do that. But we can take a stand to help ourselves and one another when we keep in mind that the trauma we witness or become part of are starting to negatively influence our thoughts and behavior. For decades, Phil has investigated and dealt with the government and universities on the psychology of terrorism, which includes how it impacts victims, while Rose has assisted a range of people from various backgrounds who are experiencing PTSD. With our combined knowledge, we've assembled a list of coping standards. Though initially meant for first responders and mental health experts, the following guidelines are significant for all of us. 12 coping standards. 1. Respect the trauma and tragedy. Acknowledge and be sensitive to the seriousness of the situation and how profoundly it influences everyone, but also identify how it is personally translated in a different way by everyone with varied circumstances. 2. Look for balance. It takes an equal and opposite action to balance the terrible trauma that has happened. Start by changing the past negative trauma that may pester you with present-centered positive deeds, thoughts, words, and actions. 3. Be caring. Always show generosity by means of a willing ear, sincere smile, make eye contact, learn given names, give a gentle touch or hug. All are easy healing balms. 4. Promote community cooperative compassion. Help people form natural support groups with shared phone numbers and email contacts. 5. Stay mentally and physically strong. Do not succumb to the frustrating negative circumstance. It is very important to be sturdy when others need you the most. 6. Don't bring your own personal disaster to a societal disaster. As much as possible, put your personal emotions aside when you are helping others. You can end up being a psychological casualty yourself if you're not cautious. 7. Focus on a solution or solutions, not the issue or issues. Instead of concentrating on the trauma, past negative, move forward slowly, thoroughly, and intentionally away from the issue and to the solution, future positive. Do not end up being stuck in the past negative. Encourage chosen present hedonism, fun activities as self-rewards. 8. Honor and respect those who lost their lives or were hurt. The best way to honor those who have passed away or have sustained a life-altering injury is to find out how best to help those left or all those whom you can help. 9. Be aware of your restrictions. Leave if you find yourself slipping into fatigue, depression, or anxiety. Look after yourself. You cannot help anybody if you are not feeling up to the job. Do seek professional help if your psychological distress lasts more than a few days. 10. Extend your empathy, not only to the victims, but to their loved ones. Even harder is to show empathy to the perpetrators who should learn how to handle their own guilt and other issues. 11. Stay away from judgmental attitudes and generalizations towards ethnic and/or religious groups. Focus on understanding, compassion, and constructive actions. 12. Encourage the faculties that promote daily heroes, being sociocentric, positive, self-confident, and practice being a hero in training, while challenging the negatives of egocentrism, cynicism, pessimism, and public apathy. How do you know if you have PTSD? According to the Diagnostic and Statistical Manual of Mental Disorders released by the American Psychiatric Association, after a terrible event, if you experience signs that include sadness, anxiety, flashbacks, avoidance, seclusion, trouble falling and/or staying asleep, trouble concentrating, irritation, an exaggerated startle reaction and hypervigilance, you may have intense tension disorder, or ASD. If these signs last longer than a month, then you might struggle with PTSD. Chapter 2. PTSD in Marriage. At times, you may want to give up. Why does every little thing have to be so hard? Other times, you wish someone would just give you a manual for handling all aspects of post-distressing tension disorder, or PTSD, or complicated PTSD. Would not it be good if the physician gave you a handbook when they gave you or your spouse the diagnosis of PTSD? Because the absolute worst part is that you have no real idea of how this new acronym will affect your relationships. However, there are several ideas readily available for you regarding your PTSD in marriage. Your marriage and PTSD. You and your spouse didn't choose to have PTSD enter your marriage. Although you cannot manage what has happened to you does not mean that you cannot have a stronger marriage. Anybody can search for PTSD in marriage all over the web. But what they normally find are a number of websites and short articles listing discouraging divorce statistics. Many of these sites and posts are terrible to read. That is a result of the fact that they can affect you to lose hope for your relationship. Although what you read is disheartening for couples dealing with PTSD, you do not need to belong to these statistics at all. I am not. And my journey with my partner who has complicated PTSD, or CPTSD, has not been simple at all. Actually, our marriage is stronger than ever before. There was a point where I didn't really believe that we would make it. Now, don't get me wrong, I was motivated and extremely enthusiastic for a long, steady time after my partner's diagnosis. Despite getting rid of challenges and having persistency, more challenges developed. After about 1 year and a half, I really lost all hope. Then, I wound up being very depressed. In fact, my psychiatrist identified me with major depressive disorder. Unexpected to me was my next analysis of vicarious PTSD. In most circumstances where PTSD and marriage don't blend well, the non-PTSD spouse might develop vicarious PTSD. Basically, this type of PTSD progresses from exposure to the trauma that takes place in the middle of your partner's PTSD episodes. PTSD in marriage. Initial steps to take note. Here are the very first steps to take if your marriage is facing PTSD. I have split up out steps for each partner. As a matter of fact, there are steps for each of you to take and some that will be a collaboration. Of course, I'm not a physician, but I have learned a lot over the last couple of years. Aside from that, what I have found is that PTSD and marriage do mix. Comparatively, a couple wouldn't divorce for the reason of one partner losing an arm or having cancer. So why would a couple separate when a behavioral health issue surfaces? Not to discuss, the US already has high enough divorce rates without the presence of a mental health disease. Not to mention comparing PTSD and marriage data show that rates for divorce increase incredibly. Partner with CPTSD or PTSD. If you are not in treatment, please find a local therapist who concentrates on trauma. It cannot be uttered enough just how essential treatment is for PTSD in marriage, not to mention PTSD alone. If there's any drug abuse present, find help. When you are talking to potential therapists, ask if they're certified to deal with both trauma and substance abuse. Additionally, don't be humiliated. It is not unusual to find PTSD and alcohol or substance abuse combined together. Research often to find relative posts to read about with info about PTSD. There are so many wonderful resources online, like NAMI, with content consisting of methods to self-manage your symptoms. Then try a few of them, but try the techniques several times. Just because subsequently, trying anything that's new can feel awkward in the beginning. Soon enough, you are going to have your own personally picked grounding and soothing tools in your toolbox. On the good days that PTSD symptoms are not active, do something thoughtful for your partner. By all means, your authentic acts of love and compassion will nurture your marriage. With this objective, you'll strengthen the love, security, and security that your partner needs to feel. Process through any guilt you keep holding on to pertaining to your PTSD in marriage. After you experience a PTSD episode, you may have emotions of guilt or embarrassment. Regardless of these emotions, keeping any guilt distracts from your relationship. If you stay in this headspace, you are going to, in addition, miss out on valuable time living in the moment with your spouse. Don't worry about past events or anything in the future. Think only about the present day and how you can enrich the next 24 hours spent with your partner. In the exact same fashion, it is extremely healing for you to be focused and in the moment often as possible. Get involved with PTSD support systems. Facebook has some groups for this dealing with PTSD. In addition, these groups offer motivation, personal privacy, and a huge support group. Some of my favorites are PTSD Friends, Women with PTSD, United in Complex PTSD Healing, Spouse Without PTSD or CPTSD. Help your partner find a pretty good therapist that has experience with trauma victims. They will have the ability to teach your partner the tools that they really need. Hence, PTSD or CPTSD sign management. Naturally, when your loved one has the ability to manage their signs, your relationship will take a turn for the better. There are self-guided practices that they can do to minimize the symptom severity. And the same thing goes for reducing an episode's period. Educate yourself on these practices so that you can help them out of their PTSD episode so long as it is safe for you to do so. Build a support system for yourself. Due to caring for a spouse who experiences PTSD and marriage obstacles, it is similarly crucial for you to find enrichment. Maybe you can make a new good friend. There are a few online platforms for the spouses of those dealing with PTSD. With that being said, here is a couple that are helpful and designed with you in mind. Additionally, these Facebook groups offer a personal place where you can get advice, get in touch with others in your situation, and find motivation. Partners and Family Members PTSD Support System. PTSD Spouses and Family Support. Spouses dealing with military PTSD or TBI. Take some time to look after yourself. Equally essential is nurturing yourself so as to keep a positive frame of mind and serene heart. Naturally, you more than likely have taken on the role of caretaker for your partner. With that being said, a caregiver's role is never ever simple. Furthermore, it is simple to lose yourself and wind up on autopilot as your partner's caregiver. If you don't take care of you first, then you cannot really look after anybody else the manner in which you want to. Release any resentment toward your spouse. You may not even recognize that you have feelings like this. Because of your partner's condition and symptoms, you may be mad or hurt. Though, please keep in mind that they did not ask to develop PTSD or CPTSD. The person they end up being during PTSD mode isn't their true selves. That individual is somebody who temporarily took control of your partner's mind and body. Contrary to this, however, it is especially appropriate that your spouse learns to take ownership of their signs. Meaning, acknowledging that PTSD and CPTSD symptoms are vicious and that they can be managed. When managed properly, there will be less of a result on you. Familiarize yourself with your partner's triggers. By doing so, you'll be able to help avoidance of a PTSD episode. Speak about the triggers with them. Learn why someone or something, a specific behavior or experience is setting off. By all means, keep in mind that you don't always need to discuss the terrible event or series of traumas unless your spouse demands to. But you just want to help keep away from or resolve a trigger with your partner so that it can be gotten rid of. Educate yourself on the best case situations and worst case situations. Do not wait until something terrible or until their signs get so out of control to start looking into all things PTSD. Learn now and continue to inform yourself so that you can always be prepared. Learn what signs to search for relating to suicide and self-harm. Additionally, having suggestions to show support in front of mind will guarantee that you remain helpful. Consequently, your partner will feel safe and secure and comforted, causing signs of anxiety to decrease. Whenever possible, express your love and gratitude for your spouse in an unbridled way. Remind them that they're fantastic and that you really love them. Due to their depression that accompanies PTSD and CPTSD, their self-esteem has plunged and they really need reminders that they're needed, really wanted, and appreciated. Read The Post-Terrible Tension Disorder Relationship by Diane England, available on Amazon as an entirely free download. Reading this book will give you a new perspective and act as a critical turning point in your role of your partner's PTSD in marriage. PTSD in marriage. Hope for the future. The two of you should have the most improving, loving, and strongest marriage. Most prospectors will say that PTSD and marriage don't mix. They would definitely agree that the stats surrounding PTSD and marriage are very high. Notably so, they haven't been in your shoes. It is very hard for somebody beyond your marriage to comprehend what the two of you really go through every day. Due to this alone, you and your partner should continuously work on creating stability, strength, and impenetrable love. Your marriage, your family, and each of you will find the peace that you are frantically seeking. I hope that this article has been practical. You aren't alone, and your marriage can make it through all the storms of life. Chapter 3: The Ways We Grieve. Bereavement After Death. Death simply acts as a punitive tip of an individual's mortality that we will one day die in addition to those that have left us behind. In spite of its inevitability, seldom are we adequately equipped to deal with the real pain and emotional turmoil that follows a real, a symbolic, or an intangible mental loss. Other sorts of events can be equated with the loss of a loved one, like the loss of a person's sense of safety after she or he experiences a traumatic event. When we are deprived by something or someone we valued, which is generally the case when a person we really love dies, what follows is a unique period of grieving, sadness, and emotional distress that is called bereavement. Our coping systems, cultural norms, support groups, as well as the situations of the death and our relationship with the deceased individual, might all contribute in how we react to a substantial loss. Typical grief responses. Bereavement and other kinds of losses, loss of health, identity, finances, can cause extreme periods of sadness, rumination about the loss, and other problems that can be difficult to handle. Grieving, or the outside physical, psychological, and mental expression of loss, can trigger us immense emotional and physical suffering when somebody or something we really love is eliminated from us. Sorrow can deplete you to such a level that the tiniest jobs become significant, and what formerly was easily possible now might appear insurmountable, wrote Therese Rando, Ph.D. Though sadness is often one of the extreme emotional reactions that take over in our immediate reaction to losing somebody we love, it is definitely not the only manner in which grief can manifest itself. Although everyone responds to loss in different ways, we hardly ever are prepared to deal with the pain and psychological turmoil that results after we lose a person or something inherently important to us. Sorrow is more than just sadness. Sorrow can manifest itself in the form of enormous emotional and physical suffering, and we might experience anything from anger to denial, to guilt, to sadness and despair. Initially, people who experience sorrow may experience confusion, shock, and shock that their loved one has passed. Yet, after the preliminary shock has passed, highly perturbing emotions can add to anxiety, extreme fatigue, sobbing fits, dreams, and even nightmares about the deceased. Sorrow manifests itself in lots of ways, not only unhappiness. Depending on these scenarios, even anger and rage may conquer us. We might find ourselves talking with or perhaps cursing at the dead people we loved or hated. We might think, "How could you do this to me? Why did you leave me? Why were you so senseless? Why did you take the dangers you did? Or, why didn't you go to the physician?" Sometimes it is simpler to be mad than miserable, since sadness, sorrow, and depression are mental and even physiological states of powerlessness and vulnerability. Anticipatory versus terrible sorrow. One day we might get up and a loved one is identified with a terminal disease, or we may discover that one of our loved ones only has a short time left to live. Anticipatory grief doesn't always happen when a death is expected, but it is a kind of sorrow that happens before the individual dies. Anticipatory grief helps to prepare us emotionally to deal with the loss that's to come. It enables us to apologize, forgive, and say, "I really love you," before it's too late. Even though lots of people really wonder how it can help to prepare us for the ultimate loss of our loved one, it can result in depressive signs in people who are prone to depression. On the other hand, terrible sorrow may be experienced in certain situations, depending upon the terrible nature of our loved one's death. Distressing grief is more likely to be experienced when we are confronted with a sudden, violent, and/or unexpected loss of a loved one. The experience of trauma and sorrow at the same exact time can turn our world upside down. It can be very painful to experience distressing sorrow, as we might find that sentiments and triggers can easily remind us of our loved one. Specifically, when our loved one's loss was abrupt, we may find that thinking and remembering our loved one fuels uncomfortable memories and flashbacks that can make us re-experience our loved someone's death. The experience of trauma and grief at the same time can obscure the resolution of our bereavement. As tons of us try to keep holding on to our memories of the person or perhaps tangible objects that are intrinsically valuable to us in fear that we might forget somebody who meant so much to us, the typical remembering of the deceased can even wind up making complex matters and even triggering us more damage. Handling loss. It was Bowlby, 1969, who originally made his name by studying babies and babies of parents or caretakers who passed away in the fight of Britain during World War II. These babies couldn't prosper and later died regardless of getting extensive nursing and medical care. Based upon his work with infants, Bowlby recognized the importance of attachments with others and believed that the bereavement process is our natural response to damaged attachment bonds. Part of the reason that our experience of grief is so agonizing is that we should learn how to let go of our attachments following a significant loss. Attachments, or bonds that we form with significant people in our lives, continue to exist even in the absence of that person. In our protest of separation from our bond with our loved one, we may have anxiety and trouble comprehending the loss, an experience referred to as numbing, which can cause feelings of shock, denial or shock, specifically when the death takes place all of a sudden. Sorrow pangs, yearning, lack of organization, and anguish. We may have debilitating frequent pangs of painful feelings, with extreme yearning, longing and searching for the departed, and fixation with thoughts of the loved one, says Mary Frances O'Connor and her associates. Sorrow pangs, short, temporary periods of extremely extreme distress and yearning for the deceased, can spin us into an existential, emotional, relative emptiness. In spite of being highly upsetting, sorrow pangs satisfy of recovering and reuniting with the person who has left us. When we recognize that we won't be able to recover the one we really love, we go through a period of poor organization and anguish, during which we try to find ways to handle our permanent loss. Together with our considerable loss, we may also feel as though we have lost a part of ourselves, and, in some ways, we did. Both tangible and intangible mental losses, like losing our sense of security after something distressing happens to us or changes to our identity, can be highly upsetting. Eventually, we should learn how to reorganize our sense of self and find our special place in the world without our loved one. Unsolved, complicated grief. Grief after somebody we really love dies can be frustrating and even distressing. Though many people can successfully handle and adjust to a loss, individuals who have lingering pathological or terrible sorrow might need to seek professional services to conquer their psychological pain. Extreme and illogical grief brought on by mourning a loss was described by Freud, 1917, as melancholy or depression. Whether the loss was real or symbolic, he actually believed that unsolved emotions of guilt and other negative feelings stemming from the loss of somebody we held dear could subsequently be directed inward towards oneself, which he called introjection. Bowlby, 1980, later suggested that the neurophysiological procedures that produce changes in our affect, behavior, and cognition can be lengthened or magnified in the face of complex or unsettled grief. The signs that develop during complicated grief responses can be so serious that they may even look like those experienced with significant depressive disorder, or MDD, anxiety disorder, or post-traumatic stress disorder, or PTSD. Persistent complex bereavement disorder. Although the sadness and other feelings that stem from the loss of a person we loved might never entirely go away, sorrow and unhappiness that stay serious, overwhelming, and lingering might mean that we're stuck in mourning, a quality of complex grief, and it can begin to influence our functioning in daily life. Sorrow throughout bereavement might itself induce such great emotional and psychological suffering that it can impact how an individual functions in his or her life. For this reason, persistent complex bereavement disorder has been proposed as a condition that might warrant scientific attention in the Diagnostic and Statistical Handbook of Mental Illness, DSM-5, American Psychiatric Association, 2013. Recuperating from bereavement. Although handling grief is a normal part of loss and bereavement, we can experience and deal with loss in different ways. Loss can bring us closer to people who are still in our lives and offer us with a unique opportunity to discover more about ourselves. Ultimately, the physical aching and pain subside after the death of a loved one. Our cherished memories of our loved one, and if they're family, our hereditary inheritance and all of the implications therein, can in some cases stick with us for the rest of our lives. Facing death need not result in anguish that strips away all purpose in life. On the contrary, it can be an awakening experience to a fuller life, said Irvin D. Yalom in his book, Staring at the Sun, Getting Rid of the Terror of Death. Chapter 4. What Everybody Ought to Know About Survivor's Guilt. Survivor's guilt is just something that people experience when they've made it through a lethal circumstance and others might not have. It is typically seen among Holocaust survivors, war veterans, lung transplant recipients, airplane crash survivors, and those who have endured natural disasters such as earthquakes, fires, twisters, and floods. The signs of survivor's guilt differ, but here are some possible clues that someone is experiencing it: having flashbacks, feeling irritable, having difficulty sleeping, feeling immobilized, numb and/or detached, being uninspired, feeling helpless, having an extreme sense of fear, experiencing physical symptoms like headaches, stomach aches, and palpitations, having suicidal ideas. In truth, it's not sensible for somebody to feel responsible for another person's fate, but guilt isn't something we necessarily have any control over. Nevertheless, survivor's guilt is a regular reaction to loss. Not everybody experiences this kind of guilt, but it's often a feeling that's hard to shake. It's been said that some people are more prone to it, such as those a history of sadness and low self-confidence. There are also other factors that could incline someone to survivor's guilt. For example, Alan Siegel, 2005, studied on the Imagine Firestorm survivors, which offered revealing results. He found that those that were victims of childhood trauma were a lot more susceptible to dreams about death, and that all healthy defenses are damaged by trauma. Unresolved past losses typically end up being psychological Achilles heels or survivor's guilt. 2 different times, I needed to evacuate to hotels, first for the fires and after that for the mudslides. But fortunately, my home was untouched by Mother Nature. I actually believe that when experiencing survivor's guilt, it's a great idea to simply acknowledge it and call it what it is, simply because it does not disappear if one quelches these feelings. It's not about healing the guilt so much as it is about shifting an individual's perspective, and the passage of time can help exceptionally. In his book, Guilt, Shame, and Anxiety, Peter Breggin suggests that we try to eliminate ourselves from negative ideas and feelings and change them with good sense, rational views, and love. Here are some coping pointers if you or somebody you know is experiencing survivor's guilt. Give yourself time to grieve. Consider thinking of who was really responsible, if anybody. Remember to look after yourself physically and psychologically. Think about how those who are close to you are feeling about the circumstance. Remind yourself that you were given the gift of survival and feel good about it. Try to be of service to someone or something. Remind yourself that you're not alone. Be patient. Share your emotions with those you trust. Try to stick to an everyday regimen. Consider journaling your emotions. Get expert help as needed. Chapter 5. The 6 best tips for handling survivor guilt. When catastrophe hits those closest to us but leaves us unharmed, some of us thank our lucky stars, but others feel guilty. Why not me, we ask, or what could I have done to stop this? These declarations are the hallmarks of an informal but very real phenomenon called survivor guilt. When an individual really believes they have done something wrong by enduring a terrible event where others have died or otherwise surrendered, survivor guilt takes hold. It can manifest across the spectrum, from bittersweet emotions to full-blown anguish. Most frequently, survivor guilt takes place after a massive catastrophe, like battlefield deaths or plane crashes, but it can also appear in unanticipated ways. For instance, a college student from Syria concerns over the fate of his family and country while he studies mathematics in the United States. He says, "I didn't do anything to be worthy of being safe. How can I sit and play with numbers all the time when my family is suffering?" Or, a cancer support group mourns the loss of one of their members, asking one another, "Why did she die while we're still here? Why are we the lucky ones?" Or an employee who keeps her job while her similarly certified colleague is laid off in a business, right-sizing worries about her unjustified benefit. "Why do I get to keep my job?" she asks. Finally, a guy grieves the loss of his sister, who recently committed suicide. He misses her with all his heart and blames himself. "If only I had kept in better touch with her, I could have stopped her." There are scores of examples, but in general, survivor guilt falls into one of three themes. 1. Guilt about enduring. This is what we generally think of when we think of survivor guilt. If you stayed safe while others suffered, you might not feel worthy of being safe and should have been damaged too. You question the fairness and justness of the world. 2. Guilt over what you should have done. You feel sorry that you didn't do enough. You should have known. You should have tried harder. Perhaps you tried to rescue somebody but failed. There's an inflated sense of failure or responsibility. If only I had done something in a different way. 3. Guilt over what you did. You might also feel guilty for things you did, from pushing others out of the way to run from an active shooter, to escaping poverty by leaving your family for better chances abroad. Or you may feel extreme guilt for things you did that were simple coincidence. On the day the music passed away in 1959, country music star Waylon Jennings was supposed to be on the plane that killed Buddy Holly, the Big Bopper, and Ritchie Valens. When he told pal Holly he had quit his seat as a favor to the flu-stricken huge Bopper and was going to take the unheated trip bus, Holly joked he hoped Jennings froze on the bus. 20-year-old Jennings joked back, "I hope your old plane crashes." In an interview decades later, he said, "God Almighty, for several years I thought I triggered it." Jennings said he tried not to think or discuss it, which is a typical response called avoidance. Survivor guilt isn't an official diagnosis, but it is associated with PTSD, which is very much a main diagnosis. Avoidance, together with feeling on edge, watchful, detached, and quickly stunned, are core signs of PTSD. PTSD-like signs aren't the only signs of survivor guilt. Additional signs include obsessing over what took place, feeling puzzled, unworthy, or ambivalent about living, harping on the meaning of life, or being afflicted by the sense that no matter where you go, you are never ever truly safe. The resulting self-condemnation and seclusion takes a toll on your health and relationships. If you are affected with survivor guilt, what can you do? It takes time and patience, but here are 6 things to try when your extreme existence makes you feel guilty. 1. Ask who is truly responsible. Remind yourself who, if anybody, is actually to blame. Is the Syrian college student really accountable for his country's suffering? No. Look to the Syrian government, ISIS, and the other global forces out of his control. Is the worker responsible for her co-worker's dismissal? Of course not. Look to the corporate leaders, ill-considered policy, even the marketplace. In the end, you should mourn those who were lost, but do not take on the guilt for the loss. Other times, there's no one accountable. It could have been a natural catastrophe or random misery. Nothing you could have anticipated, prepared for, or prevented. Regardless, we still feel responsible. Each of us overstates how much we actually knew before an accident. I should not have left my hair straightener plugged in. I should not have gotten in a car with defective brakes. This misrepresentation causes a distorted evaluation of responsibility. Why do survivors have an inflated sense of personal responsibility? In situations where you could not possibly have known or stopped events, but you still feel guilty, guilt may be functioning as an incorrect sense of control. When we feel blame but take on the burden of responsibility, we tell ourselves that it was not random or irrelevant. Guilt feels lousy, but it secures us from the much more overwhelming feelings of helplessness and powerlessness we experience when we fall victim to the unjust and unruly impulse of random forces. 2. Remind yourself you can deal with unhappiness and loss. As awful as the guilt is, it can be simpler than handling devastation brought on you by sorrow. Focusing on guilt can be a subtle or even subconscious way to avoid sadness. However, keeping away from the true feeling bubbling underneath the guilt makes things even worse in time and stands in the way of moving forward, accepting what occurred, and feeling better. It's not unsafe or bad to experience extreme feeling. You can experience and overcome your emotions in any way that suits you. Maybe you're the scream and cry type. Maybe you diary about it to get your emotions out. Maybe you just want to be quiet and alone for several days. Any is all right. Whether quiet or loud, sadness and strong pain are not felt in one particular way. The best way to let yourself feel is the way that works for you. 3. Think about how people who love you feel about your survival. Even if you presume, in some way, you should not still be here, remind yourself of who would be devastated if you were not. Think of all the people who care deeply about you and who are overjoyed and relieved that you are all right. You have actually been given the gift of survival, so rather than rejecting that gift because you in some way feel undeserving, share it with the ones who love you. At the minimum, they deserve it. 4. It's not a zero-sum game. Hidden beneath survivor guilt is the idea that there's only so much luck to go around, and that benefiting from good luck means that someone else is being denied of it. However, luck is random. The lottery game is a best example of how approximate luck is. At times, no one has the winning lottery number. Sometimes multiple people share the prize. The chances of you particularly hitting it big aren't increased or reduced by anyone else's picks. It's hard to accept that there's no greater order to things, but when we do, we feel vindicated. 5. Do something meaningful for somebody else. At least, guilt can be a motivator for purposeful action. While we might think of guilt as regrets about the past, it also makes us anticipate the future. Feeling guilty drives us to make things right as best as we can. We find ways to celebrate, serve, and honor the ones that were lost, giving us a real chance to, in our minds, minimize some of the guilt we feel. For instance, a classic 1966 study split participants into two groups. Half were told that the research study job would help their partner, who was secretly a Confederate, earn perk points in a course he desperately needed to pass in order to graduate from college, keep his job, and support his wife and kid. The pressure was on. The other half were told the Confederate was auditing the course and therefore didn't really need the reward points at all. After working on, and failing at, 3 impossible jobs, the researchers notified each participant that they had not made any bonus points for the Confederate, therefore inducing guilt. To make matters worse, they were told the Confederate had earned many points for them. As each participant left the research study room, another Confederate impersonating a volunteer for a regional blood bank approached and asked if they would contribute blood. Unsurprisingly, participants who felt guilty about imperiling their partner's job, potential customers, and family security were much more likely to concur. The act of giving blood plainly had nothing to do with the situation at hand. But to the participant, It kind of felt like a favorable act to balance karma. The reasoning behind the agreement might have been faulty, but it made them feel better and led to a good deed at the same time. 6. This goes without saying, but look after yourself. If you've survived a harrowing experience or have otherwise been left, taking care of yourself, both physically and mentally, is important for healing. Eat well, sleep well, move your body, and find support to help make sense of everything. Guilt has a location in our emotional collection. It inspires us to make amends, but with survivor guilt, it's misplaced. So grieve your losses, but remember that it was not your fault. Others are glad you're still here, and that you can use your survival to pay it forward. Chapter 6. The 4 kinds of sorrow no one told you about. The word sorrow has become understood exclusively as a reaction to death. However, that narrow understanding stops working to encompass the variety of human experiences that produce and set off sorrow. Here are 4 kinds of grief that we experience which have nothing to do with death. 1. Loss of identity, a lost role or association. Examples include an individual going through a divorce who feels the loss of no longer being a spouse. A breast cancer survivor who grieves the lost sense of womanhood after a double mastectomy. An empty nester who grieves the lost identity of parenthood in its most direct form. An individual who loses their job or changes careers grieves a lost identity. Somebody who leaves a spiritual group feels the loss of affiliation and community. Whenever an individual loses a primary identity, they mourn a lost sense of self. They're charged with grieving who they thought they were, and ultimately creating a new story that incorporates the loss into their personal narrative. In some circumstances, the identity feels taken, as in the cases of the individual who feels blindsided by divorce and the breast cancer survivor. For those people, the grief might feel intensified by the absence of control they had in the decision. Others choose to shed an identity, as when it comes to changing careers or leaving a religious community. Despite the fact that this may sound easier, those people may feel their sorrow compounded by the ambivalence of picking to leave something they will also mourn. They might feel less entitled to their sorrow and lost sense of self, because the decision was self-imposed. 2. Loss of security. The lost sense of physical, emotional, and psychological well-being. Examples include survivors of physical, psychological, or sexual trauma who struggle to feel safe in everyday life. Families experiencing eviction and real estate instability who feel unprotected and unsteady. Kids of divorce who grieve the loss of security in the intact family, though they may not articulate it that way. Members of a neighborhood who came across violence and feel destabilized and unsafe. A person finding their partner's romantic infidelity who may feel mentally unsafe in the relationship. On a fundamental level, we expect to feel safe in our homes, our communities, and our relationships. The lost sense of security, be it physical, after a break-in, or emotional, after an affair, can make an individual's world feel definitely hazardous. Symptoms of lost security might include a sense of hypervigilance, even in the lack of risk or numbness. For many, particularly those struggling with trauma, numbness and hypervigilance happen intermittently. For survivors of trauma, violence, and instability, that feeling of internal security may feel hard to restore, even if situations support. Aside from healing from the trauma, the individual is tasked with grieving the lost sense of security and learning to restore it. 3. Loss of autonomy. The lost capability to manage one's own life and affairs. Examples include an individual with a degenerative health problem who grieves the loss of physical or cognitive capabilities. An older adult no longer able to take care of themselves who grieves their decrease. This may also connect to a lost sense of identity as a contributing member of society. A person experiencing a monetary obstacle who feels a lost sense of autonomy as they count on other people's help. This kind of grief cuts to the core of everyone's need to manage their body and their life. Loss of autonomy activates grief over the lost sense of control and the struggle to maintain a sense of self. In cases of health problem and handicap, lost independence, and typically lost identity, marks every step they take. New forms of decrease invite sorrow for their lost self-reliance and ability to operate. A person suffering from a profound financial obstacle may experience this same feeling of loss, manifested as feeling their choices shrinking, in addition to a sense of failure or despair. They are charged with grieving those losses and reconceptualizing who they are in the face of these restrictions. 4. Loss of dreams or expectations, dealing with hopes and dreams going unfinished. Examples include an individual or couple who deal with infertility, an overachieving student who has a hard time to find their place in real life, an individual whose profession trajectory doesn't reflect their expectations, a person whose community took a political turn in an unwanted direction. This kind of sorrow is identified by a deep sense of disorientation. A lot of us walk around with a vision of how our lives will play out and how we expect the world to run. When life events violate our expectations, an individual can experience a deep sense of grief and unfairness. An individual or a couple struggling to conceive, and the student who has a hard time to make their method the world, may experience a sense of failure that compounds the grief process. They may find themselves comparing their process and results to others. Unexpected political shifts can cause a lost sense of the assumptive reality and the sense of stability from believing they understand how the world runs, restoring the word sorrow to its proper place. Loss of identity, security, autonomy, and expectations are all losses that warrant a sense of grief. Grief and mourning as a framework can help each of us resolve a moment or chapter of turmoil with the gentleness we give a mourner. The mourner gets empathy and is entitled to anger, unhappiness, feeling numb, disorientation, and non-linear healing. The word sorrow both properly defines the internal reality of the process and legitimizes and concretizes the process to ourselves and others. While many experience the setbacks and disasters of life with sorrow and mourning, many feel they're not entitled to the word. This has been PTSD, How to Handle Trauma in Marriage and Survivor's Guilt by Jennifer Wartz. Narrated by Brandon Suku.